athletes. I've had a great, been very lucky to have worked with him. Now, one of his greatest successes is multidisciplinary work. So I'd like to hear not only what he has to teach us, but also for all physicians, physiotherapists who are here. Everyone will say that the teamwork is so important, and if there's any questions you have, then I'm sure he'll be able to answer. Germán, he's going to talk about the real world in the process of training. So I'll leave you in the very capable hands of this great professional to talk about his experience, and I'm sure we can all learn very much from it. Yes, good morning, everyone. It's a great pleasure to be here with you. I'd like to thank Sergio and the whole structure behind him. I'd like to thank Premium Madrid, the University School of Real Madrid. I'm very happy to be here. Now, we work with myofascial injuries. And this is something impossible to avoid. I've had the great luck to be able to work in a number of different sports and a number of different levels. And this has helped me to understand all the sort of environments that athletes work in, and the different phases in an athlete's career. So I'm going to talk about some of the processes of training. So I'll begin. For me, it's very important to understand that we're working with people. And we have to understand people as a whole complex of elements. Now, we have to simplify things and be analytic to make it easier for us, but the real world of the human being and everything we do within movement or apart from movement, and within sport and outside of sport, human beings are very complex. And so very often it's difficult to measure this and to really understand it. Now, if we talk about a preparatory process, so with everything that an athlete does in their day-to-day life, to be successful, to do what they need to do. Now, this might seem very theoretical, but I want to mention it briefly because it's very important to understand these principles. Now, perhaps within this complex environment, the quality and quantity of training, this is perhaps what we can best control. And now, how athletes eat and how they rest is very important. And the state of health, and the environment as well, where they live. Now, there are all a number of internal factors, of course, when it comes to injury, which we have to understand. And then, of course, the external factors, which are always there. And often the athlete has to understand all these elements. You have to take it a holistic approach. So the question, why do we train? Was to improve our performance and also to try to reduce injuries. It's impossible to completely get rid of them, but we can try to reduce them. And through this process, and also how to get players back after an injury as soon as possible. Now I'm going to talk about myofascial injuries. Now, everything that we plan in the preparation of an athlete, some of it is to do with improving their performance, some of it is to do with reducing their injuries. So it's an integral process, training, performance, avoiding injuries, and getting players back after injuries. And of course, there's various different disciplines within this area. Now, I worked alone when I started in football and children's rugby. None of this existed. I worked with a lot of physiotherapists, with a lot of doctors. Other times I've worked without a physiotherapist, without physicians. And there are times where I've had to do a bit of everything. And so I've understood the importance of having colleagues from other disciplines working with me. Now, this is a whole process. Everything that we do for performance can help us to reduce the likelihood of injuries. Now, understanding all of these risk factors, previous lesions, surgery, understanding the personal characteristics of the person. So throughout this whole process, very often we want to simplify things because things are very complicated, but we have to try and look at certain weaknesses and strengths to improve the quality of their movement. We also have to analyze what sort of loads are most likely to cause injuries. Nowadays, players have a lot of games. We have to analyze chronic loads, things that take place day after day, so that players can adapt themselves to high loads, and that can protect them from injuries. And then there's acute loads that they have to be able to support. Then we have to educate the players, because they spend most of the time away from training, obviously, so it's important that they know how to rest and how to eat, and the recovery phase is a very important part of this process. And between all of us, we have to design the sessions. There's something I always ask myself. When I started working with football and basketball players, with Olympic teams, I realized that every person, whether athletes or not, has so many different life circumstances. Now, I was always very interested in the demands of the sport and what needs to be improved and strengths and weaknesses of the person as a player. But when there's an injury, you have to focus on the injury itself. what injury it was, what the severity. Now, what they say sometimes is that if someone has got a headache, the cardiologist will say it's the heart, the oculist will say it's the eyes, the stomach doctor will say it's the stomach. But we have to understand the whole complexity of the person. Now, in all the different components in this complex system, the functional conditions are quite complex. The medical area is very important. Now, I was surprised by the number of studies and medical analyses of all of the new players. And there's the personal sports aspect and the social family aspect. So I'm going to give some examples. So we need to focus on the physical qualities of the player and the movements that they have to perform. And often we have an athlete with who specializes in particular skills. So they understand particular movements and symmetries, but they might, however, have functional deficiencies in terms of how they need to move. Now, if you just take these test results that just show physical capacities, it doesn't really give all the information that you need on a top level athletes. There's a great number of tests that can be done. Now, I'd like to do an analytic assessment. These are the tests that I did over the last 2 seasons. Some medical, some morphological, some strength, stability, movement. Functional tests as well, of course. And then we had a meeting with every player. And the head coach meets with the player and explains their characteristics from a medical point of view, from a physical point of view, and a technical point of view. So this is a real graph that we show to all of the players. And here are some examples. Here you can see how the functional movements are assessed. We have 4 players here. All of them except one who are over the age of 30 and have great sporting strength and with a lot of experience in sport, with great sporting performance. They're very important within their teams. And when we analyze these values, some of them have had injuries, some of them have had certain discomfort in the back or in the posterior muscles, but they haven't had injuries. But if you see how they move, I said, oh dear, look what we're going to have to do. I thought that was going to happen, but it has allowed us to establish individual protocols. Here you can see a vertical jump. Here's a test where they have to run backwards and forwards 4 times, and you can see how he stops with his strong leg, and he maintains his torso, the flexion, and you can see he has the necessary acceleration to slow down, to then to move the hip, and you can see how the adjustment takes place, the compensation. The left leg becomes is fixed, and he moves the torso, and he needs to compensate everything with the opening of the hip. And we did other tests to see. Here's a table that is simplified, so I've removed the names of the players. So have a protocol for each player according to their main deficiencies. Some had more, some had fewer. So if an injury appears, so diagnosis is very difficult. In myofascial structures, there's a lot of tissues that are difficult to see. Being able to identify where the injury is difficult. Now, of course, every injury and the symptoms, the pain, it can come from various different systems. So the million-dollar question: what day will I come back to training? What game will I be able to play in? What match? How will I perform when I come back? Will I get injured again? These are the main pillars of our work. Of course, science is very important. Experience is crucial as well. Then common sense and empathy. You have to understand the person in front of you. So here's the general theoretical structure. You can see that there aren't different phases this day to day. And here are the 4 blocks of work. And there's all the proprioception, balance, posture, on one leg, on both legs, the quality of their movements, the application of force through the core, the patterns of movement with loads, and how to then progress forwards to the side, all sorts of movements, displacement. This is a more friendly way of saying it. Now, here they start to have the right functionality. They have to work on all of the qualities that the player needs to compete again. Now, it's the trainers, the physician will have to work on this in each in their own area. So how do we begin? With what content? Well, what we've used before. how much from each person, or a little bit from each person. There's some that are more important than others. And how do we progress? Well, very much step by step. We take little baby steps and we move forward gradually. Now each we need to see how the player performs a task on a particular day. And on that basis, we can say that they need to go backwards in terms of static or back to basics, long, short, particular joint, and the different ways that we can go backwards or progress forwards in all of the different contents here. So whether we go forward or go back a bit. So what's the perfect amount per day? So quantity and quality, what to ensure the best adaptation? Well, it's impossible to know completely. And we have to say that every time there's stress and a load, we have a certain amount of fatigue and stress, and we have an adaptation. And this is a continual process. And it involves various different biological systems at the same time. It's not something linear. All systems are involved here. So what's the day-to-day life of the athlete like? We have to see what their mood is like, if they're looking at their phone the whole day, if they're having conversations with people. That's very important. You need to see how the player is, to see what part of the session they can play in. And have to see how they move, how much attention, how well they're following the indications and the recommendations, and really see how they behave during the training, and if there are any possible real-time adjustments that can be made, or possibly even have to stop the session. Also to see how the athlete is afterwards, how they feel, and then if necessary, therapeutic treatment that needs to be given, and then a session for analysis to look at the heart rate and other factors. And a daily plan that is adjusted. So we need to decide whether we need to go increase or decrease difficulties. It's a day-to-day decision. So in 4 days you see one progression, in other cases there's two. When we see things are going well, we can have two improvements consequently, or we can go up and then down. And these are different strategies you see. And if you finish these 4 blocks, during this training period, the idea is that we can see that every 2 or 3 days, regardless of how we're going, that there are days in which where the athlete just does one thing. And we need to identify when it's best to rest. So how do we assess all of this? What are the indicators to say whether the player is ready to compete? Well, of course, the quiz. There are various different tools available now, but how they feel the day-to-day, how they rest, how they eat. This is very important. And then, of course, the RPE, the functional assessment, unilateral frontal assessment in one leg, and then in both legs. And then I think this is very important to know what their physiological demand is, and how they're feeling after this training process, and of course direct communication with the athlete. This is a graph that I use. I'm finishing off now. This is the last slide. So the real world. Now, they remember there's a science, experience, common sense, and empathy, those pillars. Now, we have to understand and learn from the patient, from the athlete. We're there to train a player, not we're not training an injury. So movement is a good guide. There are no two processes exactly the same. And I didn't give any examples because there's lots of different types of myofascial injuries. And we have to go step by step. So it's like brick by brick. And we're constantly improving and doing it bit by bit. Now the process is going to be going forward, and sometimes you have to go backwards. It's not a linear process. And we have to manage stress and loads. That's very important. To learn from every decision made. You have to listen to the player. You always have to be ready to make adjustments and understand, of course, that the more people who are involved in this, the more likely things are to go well. So thanks very much. Thanks for your time. And I'll leave it over to you.
Thank you very much, Germán. What a great presentation. Your knowledge and the advice you give us on how to plan out an athlete's work is absolutely extraordinary. I would also like to emphasize the importance of keeping a communication channel open with the athlete, so that we know how they're feeling. And there are lots of factors truly out there. So many factors that have an impact on the athlete and that we have to take into account. Factors that impact risk of injury, performance of the player. So truly it was very interesting to listen to you, and once again thank you very much for sharing your experience with us. Thank you, Sergio, for the invitation. So if you have any questions for Germán, please don't forget that we'll be holding a Q&A session once we're finished with the rest of the presentations. Now, let's move on to the next speaker. Fernando, it's a true pleasure to have you here with us. Thank you for joining us. Fernando is truly in love with his profession.
El paciente puede tener algún tipo de problema en buscar por qué le ocurre.
He's constantly striving to understand what's going on with his patients. He's director of the medical area at Premium Madrid. He specializes in sports physiotherapy and chronic pain, so a great professional profile. Chronic pain is something that truly with athletes is pretty much always there, and today he'll be talking to us about manual therapy manipulation, which is something we do on a daily basis in our practice, but perhaps sometimes we don't know the reasons why we do that, and Fernando will be providing us with the clinical and practical reasons why we do this, why we use manual therapy to treat muscle injuries. So over to you, Fernando. Thank you very much. First off, I'd like to say that it's a pleasure to be here with you today. I'm truly proud of this. Luckily, I've had a chance to cooperate with Premium Madrid since its inception. I was there for its foundation. And I'm very grateful to have this opportunity. This is the result of a lot of great work that's been conducted behind the scenes. So, without further ado, I'm going to start sharing my screen.
Perfectamente. Gracias.
Can you see it? Okay.
Vale. Pues lo que comentaba Sergio, aprovecho también la presentación de Germán, que me ha parecido
As Sergio was saying, I'm going to be building on to what Germán said in his presentation. In this speech, I'll be trying to talk to you about the role of manual therapy in the rehabilitation of a muscle injury. My approach will be very practical, very hands-on. In particular, I'll be talking about manual stimulation and all the several different structures that are involved anytime we are treating a myofascial injury. Professor Josué Fernández Carrero, he was actually my lecturer a number of years ago, said that manual therapy is completely recommended to treat musculoskeletal pain. It's something we always use, even if only for a little bit in our clinical practice. Systematic review doesn't exactly always back its effectiveness. It always recommends a second option, a further option to manual therapy, claiming that its effectiveness is generally low to moderate. But manual therapy does have some very good effects in the short term in terms of immediate pain relief, for example, endogenous pain relief. So it's actually something that athletes request actively. More than 60-70% of the interventions I make on a daily basis are manual therapy. On the stretcher, I treat manually injuries that are at an early stage. And so it's part of our day-to-day practice. Maybe I'm romantic, maybe I'm a little too basic, I don't know, but I love manual therapy and everything that surrounds it, along with myofascial injury treatment. In the case, for example, of low back pain, massage is a second-line or adjunctive treatment option, but it's there nevertheless. It's something we always take into account. We know that there are other strategies, education, exercise, and we know that these options have great effects on the medium and long term, but at the same time it's important to generate positive feedback while you're treating a patient. So if an athlete comes to you and you treat them manually, they immediately get better, though only in the short term. As Alvaro was saying, you can perfectly treat an athlete and they'll feel better 2 hours later. So it's a short-term benefit, this one, granted, but nevertheless it's an interesting proposal because the athlete that's just come to you will feel more comfortable. Therapeutic exercise lies at the core of our activity, of course, but manual therapy does have some space in this pyramid, especially for short-term benefits. So this is a study by Chad Cook about the benefits of manual therapy. The benefits are physiological, psychological, biomechanical, and its effect is immediate, fast-acting. And that's very important because I don't know, right before a training session, for example, right before an important match. That's something that even athletes request. So here you have a list of further benefits of manual therapy: proprioception, balance, pain relief, better reflexes, nociceptive reflexes, better sensitivity, etc., etc. This is the concept of MIH, manipulation-induced hypalgesia, pain relief, basically. So this therapy option has clinical benefits, as you can see from the studies. It is basically a mechanic stimulation, a manual application that we always have to look at as an option anytime we're treating a muscle injury. There are several factors that contribute: peripheral factors, spinal factors, supraspinal factors. There's also a placebo effect here. Whenever we treat an athlete manually, there is a placebo effect that ensues the treatment, and very, very often it is useful. We always say how we have to listen to our athletes. This is precisely because we have to take care of them psychologically as well. These are the effects of touch, of human touch. It creates an analgesic modulation, effective responses, and somatoperceptual reorganization. This article in particular that I'm citing is useful because it answers a number of questions that I've been asking myself throughout my career. What happens when I touch the patient? What happens when I'm treating a myofascial injury? In this regard, it's important to generate somatoperceptual effective responses. Human touch does provide that. It provides that for the patient, for the physiotherapist. Obviously, communication and relational skills go hand in hand with this, as my colleague Sergio did. And I also want to stress the importance of a multidisciplinary team. That's something we've talked about repeatedly yesterday and today. So these are the mechanisms of manual therapy, about the response of tissue and the nervous system, about all the responses that the body gives once you apply that mechanic pressure. Once again, there is a placebo response, a sort of placebo effect that we have to consider too. I don't want to alarm you or anything, but this is a possible active mechanism that can explain some of the benefits that are commonly associated with manual therapy. So to conclude this part of the presentation, manual therapy provides endogenous analgesia. It improves a patient's tolerance to pain, which is an explicit effect of analgesia. So that's something that we therapists have to take into account. So, about the future, the study by Bishop, we can appreciate how the correct dosage of manual therapy hasn't been determined yet. It also depends on the genetic characteristics of our patients, because they're closely related to the response to manual therapy. In this study, which was published actually last month, we look at an animal model. We found out that spinal modulation produced physiological changes in the medulla on animals, in animal models. So yet another piece of evidence that manual therapy shouldn't be underestimated. So this is a little homage to Dr. Miller Wolfhart, who will be concluding his career at Bayern Munich on the 30th of June. He's been a pioneer in the classification of muscle injuries, and in this article, well, this is precisely what he does. He classifies muscle injuries. So we have here two large groups: indirect muscle injury and direct muscle injury. That often happens in sports. This is a very complete system for the classification of muscle injuries, but let's have a look at a typical injury: partial muscular tear, where the patient experience, well, a sudden emergence of pain associated with all the common clinical symptoms. This is a initialization system. M, mechanism of injury. L, localization of injury. G, classification of gravity. And R, number of relapses. This is pretty much the system. It's actually a system that's been hinted at by other colleagues yesterday. There are more pieces of work that we can look at. Baylius, the Orthrop group, they all insist on the importance of a precise, accurate localization of the injury. They often occur in the myoconnective unit, the myotendinous unit and the myofascial unit, MTJ and MFU. And that's the starting point. In football, if you want to look at football in particular, 92% of all injuries affect four large muscle groups: hamstrings, adductors, quadriceps, and calves. I'm focusing on these four groups because truly in our practice, those are the muscle groups that get injured the most. The group 2 muscles, and we've been talking about myofascial injuries. And as a matter of fact, it is precisely these four large groups that get injured the most. That was the typical image of an injured player. So, muscle injuries between 30 and 47% happen due to indirect contact. Other factors are old age, dominant leg, previous injuries. There are other risk factors. Well, these are all risk factors that we should be taking into account. And in terms of injury ratio, well, each year this rate has been going up. So this is the work we've been doing. Actually, these are reports published by the UEFA. This is what happens in indirect injuries. The rear part of the muscle is more likely to get injured, so lower limbs are most affected. And the most common type of injury is muscle rupture. Phases: degeneration, inflammation, regeneration, fibrosis. The importance of macrophages, satellite cells. All these factors need to be factored in, especially in the earlier stages. So I strongly recommend you read up about these notions. It's actually something that Stecco talked about too, the importance of regeneration, inflammation, the recursive cycle that begins when we get injured. The implication here is that therapeutic efforts sometimes can have limited efficiency, effectiveness. There are other therapeutic options such as stem cells, antifibrotic therapies, and mechanic stimulation that can represent valid therapeutic alternatives. But still, I would like to quote Dr. Garcia Olmo. Great strides have been made in medicine in the past 20 years, more than in the past 20 centuries, and yet in scarring we have made little to no progress. If we get cut and we have an open wound on our body, all a doctor can do is stitch it up. We don't know what's happening inside the wound, but truly that is the reason why athletes often have relapses, because we don't know what's happening on an inner level. So here you have a couple of instances of studies on the musculoskeletal system. The injury model is very dynamic. It's something other colleagues have also talked about. This is also another instance of a recursive model that takes risk factors into account. Load control is very important, as is it is to take into account other risk factors. Once again, age, previous injuries in the case of an ankle injury, body weight, pressure on the joints, etc., etc. All these factors we have to take into account when it comes to choosing a therapeutic option. Muscular stiffness, postural instability, an alteration in the patient's proprioceptive sensitivity. These factors, these aspects can be worked on using manual therapy. Manual therapy has been proven to effectively treat, for example, muscular stiffness or instability. So this is a critical review, because we've looked at a number of functional evaluation and analyses, but at this point you might be wondering, in spite of all of this, why is it that athletes get injured more and more often? So this is a critical review that attempts to answer this question. What's key here is injury risk detection. It's impossible to reduce that risk to zero, but still there is something, we have to do something about it. We have to treat these injuries. That's why analyses are so important, but still, and I'll start concluding here. In spite of all these analyses, 67% of ischial injuries that are clinically recovered aren't isocynetically recovered at the moment of RTP. 89% of them aren't edematosely recovered at the moment of RTP, and 42% of these injuries have fibrosis at the moment of RTP. So that means that the athlete is likely to re-injure. In spite of all we know, this is our reality. So we should reflect on that. Eccentric exercises can be very useful to reduce the re-injury factor, strength training as well. So as far as return to play goes, the consensus on international level is that these analyses of the injury that we can conduct can lead us to make better decisions. So once again, the international consensus is that these analyses provide an interesting solution to muscle injuries. Communication is also important, and progression criteria need to be perfectly defined if we want to avoid re-injury. You have to keep on working with your athlete and take all of this into account. I'm talking about qualitative analyses here. When it comes to muscle injuries, let's leave quantitative analyses to one side and focus on qualitative. EVA, tissue manipulation, localization of the tissue restriction area, low mechanical load, detection of the engaged structures, and of the nervous response under the skin of the athlete. So it's important to always bear in mind that not only do we have data at our disposal, much like other speakers have said, it's also important to analyze qualitatively those data before we treat a muscle injury. About treatment, on a national level, consensus states that, so you've got a couple of minutes left. Genic therapy, drugs, and massage therapy are options that we always have to take into account while we take care of interpreting data. Nervous system, our body is a complex unit, and the nervous system is something you always have to take into account when it comes to treating an injury. Manual therapy creates, once again, endogenous analgesia because it acts on the peripheral nervous system, but still we have to look at the whole nervous system, especially to treat muscle facial injuries. But I know that other speakers are going to be talking about this in more detail. The skin. The skin is a loudspeaker. It will tell us how sensitive the area is. That's why contact with the skin is so important, and we can generate pathoanatomic models, a neuromuscular model from there. But I also want to stress the importance of neurophysiological peripheral effects, because they lead to neurophysiological changes that affect the nervous system through its under-threshold mechanoreceptors. The primary somatosensorial cortex are our main focus of action. In this regard, let's have a look at this study. These are the underlying mechanisms. Somatosensory, for example. It's all got to do with the central nervous system. Three phenomena here: regional interdependency, cross-education, and symmetric distribution pain mirror image effect. Disorder in a remote anatomic region that may not seem to be related can still be associated with the primary injury of the patient, but we'll be looking at that in more detail later. Cross-education, unilateral resistance training can lead to increased strength in the untrained limb. Who knows me is aware of the fact that I always say it is important to treat both limbs always. This is a list of the symmetric symptoms. Patellofemoral pain is very frequent in athletes who have sore hamstrings. That happens in a lot of other structures as well. This is neuropathic pain. Because we've been talking about myofascial injuries, but this principle is also something you have to take into account. There's a list of historic studies. When you train a side of the body, you're also training neighboring areas and the symmetrically opposite area. Symmetry can be used to do a diagnosis of a functional structure or an organic injury. We've run out of time, unfortunately. Okay, leptin is also important. Neuromuscular manual stimulation, local, regional, remote, practical application, taking into account anatomical disposition, etc. Biceps muscle, triceps muscle, adductors, chest. What's key in manual therapy is being accurate, being precise in the exploration. Local and regional practical applications. This is a remote application working on the hamstring as well as the tracheal biceps. It's a new experience. So in this case, we're working on the pectoral muscle as well as the adductor. This sort of balance is called homeostasis. Characteristic manipulation that I do very, very often. And another muscle group that I always treat is the forearm. Two clinical findings: goosebumps and sweating. That doesn't always happen. Other practical applications: manual stimulation. There's neuromuscular therapy. And this is an exercise in the dynamic stretching of this muscle group.
Okay, and here you can see the effects after the mobilization. So the femoral with the quadriceps, and this is common practice. And we need an alternative for this type of lesion. So you can see how changes are generated. That can be very interesting before to training or a game. And other practical applications, of course, in the neck, upper limbs, the back, the feet. And just to wrap up, manual therapy is very important. It's really hands-on and literally. And if you have any You need a qualitative analysis, very important. The nervous system, both the sensitive and motor system, needs to be there. They have to understand each other. They're inseparable. There's and of course you need to have manual stimulation in the sense of neuromuscular stimulation. And in times of change, well, the type of work may be wrong, but we don't know. But Ramón y Cajal is very inspiring here, because he says that nothing inspires more respect than an old person who knows how to change their mind. So look, thank you very much indeed, and here you can find me for everything that you need. Thank you very much. Thank you, Fernando, for your presentation. Yes, it really is a great pleasure to hear from you. I think stimulus is key, as you said. The stimuli are very important to get responses. And we shouldn't try to change the function and structure. We have to base ourselves on these stimuli, which Fernando spoke about first, with significant understanding of the neuropathological and physiological attributes and their day-to-day knowledge of their day-to-day life. So thank you very much, Fernando. We're now going to speak to Andrzej Pilat. Andrzej Pilat is the creator of the Myofascial Induction method. He's a founding member of the Myofascial Society, and it's a great honor to have here one of the creators of this technique, which is so important to physiotherapists who work in sport. Now, physiotherapy ends up in a lot more places than we'd imagine. Now, I was very lucky to learn this method with him, and I realized how physiotherapy is able to go much further than we would have thought originally. So, Andrzej, thank you so much for your time. Thank you for coming to speak here. It's a great pleasure and a privilege to hear from you. Andrzej is going to talk about how the fascia is involved in bodily movement. Thank you very much. Good morning to everyone. Yes, I'm very grateful for the invitation. It's a great honor to be here with Victoria Gandolo, and thank you for organizing this sort of workshop and organizing it so well. I'm going to share my screen now. Okay. So participation of fascia in bodily movement. I think above all we have to answer a question. What is fascia? Anatomical studies related to fascia for a long time almost always were done with corpses, preserved corpses. Recently, we've been able to do this sort of research in corpses, non-treated corpses that haven't been treated with any chemicals, but it's just been kept at low temperatures. So here you see the back, and the skin has been separated and removed. So this is the top level of the skin, and this is the lower level. So how do we define the fascia? Well, in medical dictionaries, we can see how the fascia is defined, and I think it's quite far removed from the level of research that has been performed over the last 10 years. So that's why we need to understand the dynamics of the fascia. Because the fascia is a system. Now, the Fascial Research Society tried to reach a consensus between various specialists to come up with a modern definition of the fascia. This was published in 2016. The facial system is made up of three-dimensional continuum of connective dense tissue, which contains collagen and impregnates the body. It includes elements such as adipose tissue, neurovascular veins, aponeurosis, deeper fascia and superficial fascia, epineurus, articular capsules, ligaments, membranes, meninges, myofascial expansions, periosteum, rinacular, septus, tendons, visceral fascia, and all the inter and intramuscular tissue, including endo, peri, and epicemium. The system penetrates and covers all organs, muscles, bones, nerve fibers, and provides the body with a functional structure and provides an area where all the body systems operate in an integrated manner. As you can see, this is a very ambitious definition. So the question is, do we have enough arguments to interpret this definition? So here's a dissection of a non-treated body. The skin was removed. The head is covered, and this is the scapula here. Now here we have a very vascularized structure, and here is a video, so you can see that it has movement. You see, it's not just the scapula that's moving. Everything is moving. It's moving through the chest, the back, and the arm. Now, if you remove the superficial fascia, here we just have the deep structure. Now you can see that we're moving the upper layer, and now this is the lower part. This is the angle. Here you see again the head of the body. This is the trapezium. Now this is the infraspinal area, which doesn't just cover the muscle, but also reaches other muscles. Okay. This is the trapezium. Now have a look at this area. Now when you move this between the trapezium and the infraspinal area, there's a sliding. And this sliding has to occur correctly in terms of the width, the frequency, the speed, so that the scapular movement is correctly done. So this allows for a correct positioning so that the hand can perform its movement in an optimal manner. Now let's go back to this. If this doesn't slide, if this part that we've seen here doesn't move correctly, the trapezium is fine, but the infraspinal area, what can go wrong? Well, the relation of the movement, of the sliding movement of the fascia between these two structures. Now we're going to go a little bit deeper into the tissue. Here's the omoplatus. This is the lower angle. This is the rhomboids and the middle section of the body. This is the omoplatus. And this is the supraspinal muscle. Now if we move it from the bone structure, now please look at what happens here. So this is the omoplatus. Here's the head of the body. Here's the internal part of the scapulus. Here's the rhomboid. This is the supraspinal, which we've lifted up. And it's the infra section. So let's see the whole sequence so that you can see where we're going in the deep dissection. Again, the trapezium is sliding. Then we separate the supraspinal from the, and we do the same thing with the infraspinal muscle. Now, a movement has been performed with the body, which is an internal-external rotation of the arm. So what happens with the infraspinal? And what happens here? Now, look at this. See how the body moves and how the rhomboids react, and the neural structure. All these movements can be analyzed. Now, I think with this information, so what model do we use to understand the movement? Well, generally, is this model that we use. It's one plane, so there's a contraction, and they move the. We produce this angle in the elbow. In 3 dimensions, we're confirming this sort of behavior. Okay, if I now go to the microstructure and I want to see what's happening in these filaments, we're always talking about long movements on a particular axis. It's an approximation. The question is, to what extent is this model valid? Now, here's a dissection of one of the muscles in the forearm. Here we see the tendon. Now, not every muscle fiber reaches the tendon. There are some that are short, there are some that are longer. If you try to separate the tendon with a cut with the scalpel, I wouldn't know where to cut, because if you cut here, if you cut here, it continues. So you have to remember that the transition between the two depends on the particular fiber. So this is a longitudinal view. So my question is, the short fiber that contracts but didn't get to the tendinal body. Now, if you look at the cross-section of the body transversely, you can see that the muscle fibers don't touch each other. They communicate through this network, through the endomysium. Now, if I bear in mind all of these anatomical structures, what does science say about the muscle structure in movement? Well, there's a Journal of Biomechanics, which is a very important journal, and it says most of myofibers in the muscle don't reach any of the ends of the tendon. So the force is generated laterally, and that's defined as lateral transmission of the muscle skeletal force. Most of the results show that most of the force is generated at the end of the microfibers through the endomysium. So in other words, the angle by which it reaches the tendon is very, very important for how the muscle works. Now let's look at these 2 anatomical images. Here's the forearm. There's the carpian tunnel, it's transverse, the muscles. There's the median nerve, and here we see this is a body. Now this part of the dissection is a clean dissection. So whatever the nerves, the muscle, has been removed now. So here you can see that this would be the movement for moving the fingers. So how do the tendons work? Well, there's a lateral sliding, and this is the model that we think of. But this type of dissection is called dirty dissection, because we can't see all the same details as in the first image. But now let's look at the details. If I do this transversal image, realize that the tendon, that they're not separated in a clear way. They're combined to each other laterally. So one tendon to tendon, or muscle to neurovascular packet, and muscle to tendon. So the question then that we need to ask here, is it possible that this type of movement that we've seen so clearly in the first image occurs in real life? Is it possible to have a selective movement of a tendon? Well, let's think. Here's a muscle fiber under a microscope. So look at its thickness, its length. So it's provided ATB to activate the contraction. Now, look what happens here then. Now, there is a change in length, but here you see that the lateral diameter of the fiber has also changed. So in the transversal cut of the endomysium, you can see that the endomysium of this fiber doesn't just change its diameter in transversal, but the endomysium is next to another endomysium. So what kind of reaction is it creating here? Well, here's a study that's published in 2008. It's very interesting. And so here we stimulated this, and here's the connective tissue, which is non-specialized connective tissue. It's these intermediate areas. It doesn't even have a proper name. But you can see how this process is initiated. Now, as we allow this muscle to contract, this tissue is affected, and it reaches a maximum tension here, and this lateral stimulus is actually stimulating another muscle that has no direct message to contract. So, but it also does contract because of the connective tissue. So now this is probably not complete though, because this is the intermediate. This is also an insertion. So where does this concern come from? Here's a surgeon working on neurological patients, and the patient has a problem in the cubital flexion. The hand is flexing. Now there's no way to solve this problem, neither with physiotherapy, with Botox or anything. So they decide to do surgery with the tendon. So they cut the tendon and they perform the movement of the hand. Now see what happens with the tendon. The tendon is moving. It's moving for a distance of about 2 centimeters. Now it's cut, it's broken. It doesn't go as up to the hand. So what's the expectation? Now if I cut the tendon and I move the hand, the tendon shouldn't move, but it does move. Why is the tendon moving if it's been cut? Now here's a diagram where we see the connective tissue here, the extramuscular connective tissue, and there's a neurovascular tract here, which is now the neurovascular tract is connected naturally with the tendon and the muscle. Now when I cut the tendon, but I don't cut the neurovascular tract, and I move the hand, then the neurovascular tract moves and it drags with it the tendon. Now this is research that we've been doing recently. Here's the cubital nerve. Now this is done on a corpse, and you can see the flexion of the fingers. Look what's happening here. You can see that this movement, the connective movement, has been performed between the tendons and with the nerves. So, in other words, we can't separate the movement. Now, if I have an immobilization and I don't work on the muscle, well, when the muscle is worked, the nerve is also worked. Now, what impact does this have on illnesses? Well, here's a transversal cut of a muscle from a biopsy. Here's the perineum. Now, this is healthy tissue biopsy. And here's a section taken from a spastic muscle. Now the question is, what happens with spasticity? Why in spastic muscles do they have so much strength? Now there's research being done to this. Now here's a very interesting study published in 2015. And the aim is to research the relationship between the level of spasticity and the strength of extensive muscles in the knee and the feet in patients with hemiparesia because of a cerebrovascular accident. And the conclusion is that there's a negative reaction between spasticity and muscular strength, and there's proof that the spastic muscles are weaker. So with this sort of information, this sort of evidence, I should review the model that we use to understand movement. Now, how does all this research begin? Well, the father of all this very important process is Houdin. And Hu Jing published an important conference in Taipei in 2007. This proposal for research, which was then published in 2009. And what did he do in this work? Over the last decade, it's been shown that there's a potential for transmitting strength between skeleton muscles through connective tissue, both inter- and extramuscular tissue. The researchers have definitely proved that the epimuscular roots can transmit substantial strength. In other words, all of the fascial covering externally can transmit strength. 2011, a very interesting study is published because so far most of these studies were conducted on tissue cut out from animal corpses through a biopsy, but this is measuring the lateral force determined experimentally from a non-sectioned muscle of a mammal. So in other words, this is happening in a living muscle. This is a very important study published in 2013 on the epimuscular transmission of strength in non-sectioned muscles. So we see there's the communication of strength. The researchers look at, they say, look, in vivo observation of the gastrocnemic contraction shows tensional changes in all the other muscles of the leg. So what this means then is, say that I cause a contraction and one moves the one next to it. No, they're saying that it's not just the muscles of one particular section that react, it's all compartments that react, including opposing muscles. So the conclusion is that the leg muscles are not mechanically independent. Now, another study, and two very important researchers, Findley and Chowdhury, they've published a very interesting study saying that the presence of substantial stress during exercise, so he's talking about sport, is transmitted to the fascia. This shows that we have to have a new perspective for researching the transmission of myofascial force with implications for exercise-related therapy. Now, another thing here is that motor deficiencies are due above all to alterations in the lateral connectiveness between muscles and not so much to damage to the muscles and tendons. Another study in 2016 on the lateral transmission of force with evidence from unemboweled cadaver. This is a very important observation. This is very recent, in 2018. It says myofascial tension, so in other words, changes in the connective tissue, can occur without any changes in the length of the fascicle, which suggests that the changes observed in the forces exerted by the tendons are the result of the forces transmitted from the surrounding muscles, and they are not due to changes in the capacity of the determined muscle to generate force. So it could be a muscle that is not performing any action, is at rest, there's no contraction of the muscle, but it can transmit force because of what the other muscles next to it are doing. Now, this is an interesting study from last year where they use MRI to observe post-traumatic changes in infections and neoplastic diseases. So the water accumulation, blood residues, and they can see a filtration of the fascia into the tendons in a pathological way. And this allows us to see what tissue is injured. Because we can say, look, the muscle is injured, but what exactly is it? The muscle fiber or the connective tissue of the fascia? Now, and does this work for fascia as well? This is something we need to ask. So my conclusion then, above all, the presence of intra and extra muscular continuity in the fascia, the presence of epismal parallel route in transmitting strength. Most muscle fibers do not reach either of the two ends of the tendon and aponeurosis. The muscles are laterally collected to the structures such as the blood vessels and the peripheral nerves, and the connective tissue, both intra and perimuscular, can act as protective structures in mild to moderate trauma related to the tendon or the muscle. Now, these two studies in 2016 focus on this, and they say that the presence of a traumatic or intrinsic or extrinsic force, it seems that first what we have that there's a protection of the skeletal muscular function. So the neurovascular tract surrounds and reinforces the blood vessels, and this is a strong candidate for being part of an important route for transmitting force. Now, I think we need to review these concepts of the whole dynamics here and to try to see what tissue is really involved here. Now, I can say that I mobilize the neural system, or is it the neurofascial system? And the behavior of the physiology of the fascial system needs to be included in understanding what's happening with the nerve. Now, the issue of the fascia and the research in recent years has progressed a lot. It's difficult to follow everything that's going on. Now, I'm just trying to focus on one particular issue, one particular concept, just to spark some interest in this issue. And I'd like to really thank all of the hard work of the team that has been working with me in this research and all the teaching. We've been working for a long time, since 1996, when we all started this adventure in Venezuela, and then 12 years in Spain. We've collaborated with a number of different areas in different parts of the world. Now, if you're interested in this issue of fascia, then you can communicate with us. Here you can see how you can communicate. And I would like to take this opportunity in such an international event to do a little bit of advertising. Next week, we have my book is going to be published with Myofascial Induction, an anatomical approach. It's a large book, more than 350 images of embalmed corpses, and it's also accompanied with videos, and so you can see this in a more complete way. So once again, I'd like to thank the organizations and congratulate you for this event. And of course, I'd also like to thank all of you for listening. And this is my last message. When you're working with the patient, now wherever they are, if they're lying on a bed or they're actually doing sport, or they perform a movement, all of this is part of therapeutic movement. And if they're an athlete or not, it doesn't matter. If the movement is being performed with the hand of the therapist, or if it's a movement that they're performing freely by the patient, that the same physiological principles apply. the therapeutic process is not just to cure a patient, it's to provide the patient with the resources so that the patient can cure themselves. And I'd like to finish with that reflection. Thank you very much.
Professor, as always, I have to say it was an incredible presentation, very exciting. The importance of a global vision, the importance of stimulation. I think your presentation forces all physiotherapists to reflect on what it is we can do in our practice to bring about movement in our patients. So once again, it was a privilege, an honor to be able to listen to you. It was a great way of learning more about the successful treatment of injuries, because after all, athletes are at the forefront. We're going to be talking to Carla Stecco now. But we're going to have a 2-minute break beforehand because our technicians need to make a couple of adjustments to turn on the
es deuda, continuamos y una vez que nuestros técnicos nos han ayudado a poder organizar la traducción, ya estamos con la doctora Carla Stecco, que es cirujana ortopédica, es profesora de anatomía humana y ciencias del movimiento en la Universidad de Padova, en Italia. Es miembro fundadora de la Asociación de Manipulación Fascial y de la Sociedad de Investigación Fascial. Bueno, pues Carla, nice to meet you. It's a great pleasure for us to being here with you. It's for sure a big pleasure for us to hear your knowledge and also your experience, because it is quite important for us, the people who used to manage sport injuries. And thank you very much. Carla will speak about fascia anatomy and physiology, and also how fascia is involved in sport. Thank you very much, Carla.
Thank you so much for the kind invitation.
Parece que se ha caído, Sergio.
Carla, can you hear us? Carla.
Pasamos a cartela, ¿vale?
Ok. Un minuto y volvemos. Bueno, pues disculpar los problemas técnicos que estamos teniendo en la
We
conexión con
apologize
Carla Stecco.
about the
En cuanto resolvamos
technical issue. We seem unable to reach Dr. Carla Stecco.
Bueno, no obstante, vamos a continuar
As soon as we successfully
la tanda de
contact
preguntas
her,
y
we'll make
tenemos
sure
algunas preguntas que se han realizado
to
a nuestros
start her
ponentes
presentation.
de
So let's
esta
move on to the
del
Q&A
sábado.
session with
Para Germán, para Fernando y Andrzej Pilat.
the speakers from this first round table. The first question is for Germán.
Para todos los que trabajamos en el deporte, nos hemos dado cuenta que la
Germán,
actividad
to all of
y
us
el número de lesiones deportivas
who
ha aumentado notablemente
work in
desde
sports,
años hacia atrás,
it is quite apparent that
deportivas. Y esto
injuries
parece un
have
poco
become
contradictorio.
a lot more common
Nosotros intentamos hacer muchas
as of late, which seems really like a bit of a contradiction because we work a lot in terms of prevention, we do a lot of functional analysis, we do lots of things that we didn't used to do a few years ago that are all aimed at reducing this injury rate. So my question is, have personal trainers perhaps changed their training model over the past few years, or is this perhaps due to the tighter schedules that the players have? What can you tell us? It's a very interesting question. I've personally learnt a lot over the past few years, and I've actually changed my approach to this job, which is very complex, as well as my colleagues. But to me, injuries and schedules, calendars, tight schedules, as well as the increased demands for our players, all of these factors combined leads to a higher risk of injury for our players. Obviously, I'm not talking about, for example, contusions, which are normal injuries in contact sports. I'm talking about injuries that are due to overuse. 25 years ago, or even 20, 15, 10, even 5, things were a lot different. Science, I realized by listening to Andrzej, progresses so fast, and I know so little, I realize. But by treating injuries, we've learned that injured players train better than completely healthy players, because by treating injuries, we learn more about our athletes, and we're able to better calibrate their workload when it comes, I don't know, to jumping, accelerating, changes of directions, and so on and so forth. By treating injured players, we've learned more about these movements, and we've learned more about our players. It is true that because they have to compete more often, they can't train as regularly as they used to. About 10, 15 years ago, but at the same time, a lot of money has been invested in developing new knowledge, and through injury and by treating injuries, we've learned a lot. I'm a personal trainer. I'm not a doctor. I'm not a physiotherapist, and year after year, I've been able to realize how much I still have to learn. I'm in awe, actually, at all of this. We've been learning so much about human beings, the complexity of injury prevention. In the past, we used to treat a muscle injury, as a simple ruptured muscle, but now we know that it's a much more complex issue. So I've learned so much about it.
Pues sí, no es un gran debate como bien dices, ¿no? Creo que pues todos
Yeah,
los profesionales
like you
que
said,
estamos en torno
this
a
is a
la
very
salud del
thought-provoking debate.
y cuando digo todos me dejaré alguno, pero médicos,
We
fisioterapeutas,
professionals who
preparadores
work
físicos,
with
nutricionistas,
athletes,
psicólogos, los entrenadores, pero
podologists,
fundamentalmente
nutritionists,
este tipo de staff, es
physiotherapists,
importante
trainers,
que indudablemente
all the
vayamos
stuff
aportando a la sociedad justo esto que también estamos aprendiendo nosotros a día de hoy, que nos estamos dando cuenta
must
pero que estamos
acknowledge that they still have a
de la
lot to learn.
importancia que tienen
On a
una
daily
cantidad de
basis, we
factores
learn something new.
sobre el
For
deportista para que
example,
aparezca una
these
lesión. Así
days,
que, bueno, es un gran debate que nos llevaría
as of late, we
poco
have been
mucho
learning a lot
tiempo.
about what it is we
Y
still
por
don't
si
know
todas las
about
preguntas, gracias Germán.
injuries and
Fernando, un
athletes.
par de preguntas que
Well,
nos
thank you
han
very much,
realizado.
Germán. Fernando, a couple of questions for you. In manual therapy, in your opinion, what is the key factor? And also, what techniques yield the best results in manual therapy? Because by manual therapy, we mean, in general terms, touching, manipulating the tissue. Please elaborate on the very philosophy of manual therapy, and also, if you can, which type of manual therapy yields the best results. Is it myofascial therapy? Is it high-speed techniques? Is it mass therapy? Okay. So key technique in manual therapy, as Adrián also said, over the past 10 years, I haven't been around for 25 years, I'm afraid. My practice over the past 10 years has greatly changed. Our understanding of the nervous system, of how it moves, has changed greatly, and that's in turn revolutionized my perspective over my job. So the first thing is, of course, we've always worked a lot on the muscle system, on the facial system too. What's key, in my opinion, is the combination of these three systems: muscle system, nervous system, and facial system. That is key. That's the key approach. They're indivisible. These three systems can't be separated. They can't be approached individually. They are doomed to work together. In the nervous system, for example, the sensitive and motor systems go hand in hand. You can't approach them as individual systems. And then, what's most effective? Is it massage? Is it other therapies? Everything is effective. But digital pressure, longitudinal sliding, superficial techniques, deep techniques, friction techniques, pinching, rotational techniques, all of these techniques are very important. But it's, generally speaking, the combination of movement, mobilization, of the sciatica, femoral, median, cubital, radial. This mobilization of nervous system is something you always have to bear in mind by paying particular attention to mechanoreceptor changes. Within the same technique, within the same sitting with a patient, things can vary greatly after a manipulation. We can generate a lot of change using, for example, myofascial techniques or soft tissue manipulation in a matter of minutes. This cocktail of techniques, which is widely used, by the way, in about 60-70% of sittings on a daily basis, is absolutely incredible, yields great results. Once again, I may be a romantic, but it does yield great results. The patient will actually notice that something is changing, and they're very, very grateful to physiotherapists. So nervous system manipulation, I would say, is something you always have to bear in mind, as well as facial tissue manipulation. Thank you very much, Fernando.
Dicen, ¿no? El movimiento se aprende andando. Qué importante, ¿no?
We often say
Generar más estímulos para obtener más
you learn how to move as you learn how to walk. That's super interesting. We can do the same in our practice. We learn so much from our patients. And we can get closer to our goals as we progress in our treatment of patients. Professor Andrzej, we have millions of questions for you actually, but I'll try being as brief as possible. There are a couple of questions that in my opinion are very, very relevant. Are fascias nerved, provided with nerves? That is a great question to finalize the session. A facial innervation, on the one hand, is something we know a lot about. We know a lot about tendons, receptors. But we also know the specialized connective tissue is too innervated. And we knew very little in the past about non-specialized innervated tissue. Early observations were made in 2006, 2007, and then in 2011 other articles started being published about new technologies that showed that several different fibers are mechanoreceptors, that polymodal receptors, which means they're also involved in pain modulation, and that they often become activated during dissection. By acting as receptors, science has pointed out over the past few months that these receptors respond to light stimuli, even little pinches, and as a result, people often wonder what's the best way to treat the myofascial tissues, soft or hard. It depends on the circumstances. Let's just remember, however, the mechanoreceptors are richly innervated. There are other studies that have been published recently that have been showing clearly that in the lower back area, if you inject saline solution into the muscle, the fascia, or the skin, the first response will be pain. So this is completely feasible. We still have a lot to learn, however. Intense lumbar pain could be induced by facial dysfunction as opposed to disc slipping, although of course that can be an obvious issue at times. Emotion is part of movement. There is no movement without emotion. We move because we experience emotions and feelings. The fact that whenever a fascia is involved in a movement, an immediate emotional response follows means that patients are alive, whether you like it or not. We all love positive emotions, positive feelings, but as soon as we get sad, we shut down all communication channels. It's because emotion is connected to movement. How is the brain involved in this? Well, there are lots of studies into this. I think this is actually where the key issue lies. There are always psychological and emotional symptoms that go hand in hand with physiological symptoms, always. So the question is hands-off or hands-on? The key process here is therapeutic movement, and I'm very grateful to sports, in particular elite sports, because physiotherapy has focused its attention on several different systems and apparatuses, on exercising, and has developed the importance of exercise at a scientific level. That's all thanks to sports. And now we've been copying models off of high-performance athletes. So we have created an indivisible link here. Andrzej, wise words, best possible summary we could possibly have to wrap up this roundtable. Stimuli go first. A quote from Ruben Fernandez that I'd like to share with you, because this quote led me to reflect upon what it is we can do to better work with patients. Patients learn through emotion, not through manipulation, and this confirms it. Manual therapy, therapeutic exercises, that's all great, but people aren't isolated nerves. We can't just work on one single nerve, we have to work on the whole system. We can't only work on the skin. Those of us who use manual therapy, external manipulation, exert pressure on different systems, and we mustn't forget that after all we're working with people. Each and every time we do so, we're stimulating a number of different systems, and as a result we'll be getting responses from all of these systems. If you allow me, Sergio, relating to that, I haven't had an opportunity to talk about emotions and feelings a lot in my presentation, but precisely because we're talking about it, as Ruben said, it is important to take that into account. I mentioned goosebumps. Physicians can create emotions. That's why patients experience goosebumps now and then. That's something that happens relatively often to me during a manual therapy session. Patients get goosebumps because they're experiencing emotions, as well as local spasms, for example, during puncture or palpitation, when you do high-speed manipulations. And it is important to recognize that each and every time we create these emotions, that is actually success. It means you just hit the spot. It helps me. It's something I'm actually after in my practice. It's something I try inducing. When I finally get it, when I finally get that response from patients or students, I always interpret it as a very important reaction from the patient. Thank you very much. Would anybody like to conclude? Germán, perhaps? Well, another quote that I like a lot, it's common sense really. Not everything that can be quantified counts. Not everything that counts can be quantified. The beautiful thing about this profession is that there will always be more questions than there are answers. We already know that we'll never get to know everything about everything because our bodies are such a complex system. And so it's important to be aware of the fact that now and then things may be or get out of your control. When that happens, be humble. Know that you have to I know this. Be humble. Know that you have to study more, that you have to learn a lot more about your profession, and that you never stop learning. So that's my final message. Thank you, Sergio. It was a pleasure to kick off today's session by talking to you four. Thank you. Thank you very much. It's been a pleasure. I truly hope this session was interesting to you all. To me, it was certainly an honor to share this experience with you. Once again, thanks for joining us. We're going to have a further 2-minute break before we carry on to the next round table. Once again, thank you all very much. Thank you.
Bueno, pues continuamos con la jornada. Teníamos pendiente recuperar la conexión con la doctora Carla Stecco, como decíamos, cirujana ortopédica, profesora de Anatomía Humana y Ciencias del Movimiento en la Universidad de Padova, en Italia. Es miembro fundadora de la Asociación de Manipulación Fascial y de la Sociedad de Investigación Fascial. Carla, again, it's a great pleasure for us to be here with you and hear your knowledge and experience about the fascia. So thank you very much.
Thank you to you for the kind invitation. It's really a pleasure to discuss about the role of fascia to perceive pain and to affect the movement in the sport people. In that presentation, I wanted to understand if the fascia can play a role as a pain generator. And for that, I can show you some study that suggests some possible alteration. First of all, speaking about the sport people and seeing also the presentation of Professor Pilat, I can show you this study that we did in the people with Achilles tendinopathy. We know that in almost all the people with Achilles tendinopathy, chronic Achilles tendinopathy, we have an increased thickness of the Achilles tendon, and that is well known. But we try to focus also in the paratendinous tissue, that is the fascial tissue that creates the sheath around the tendon. And we demonstrate that in all these people, we have an increased thickness also of such tissue. And not only of the fascia around the tendon, but we checked also the thickness of the crural fascia in the front or far away from the tendon. And we see that there is always a thickening of this fascia. What means that the Achilles tendinopathy is a more global alteration and not only related with the tendon, but is related also to the fascia around the tendon and the fascia far away. Then a further study that I hope to do in the future will be to understand if we appear before the problem in the tendon or in the fascia. In my experience, seems that is the alteration of the fascia appear before to have an pathological alteration in the tendon. So the fascia could become also a way to do an earlier diagnosis of tendon pathology. But in the same patient, we also checked the thickness of the plantar fascia, because we know that the plantar fascia has an anatomical continuity through the fascia that go around the calcaneal bone with the Achilles tendon. And from a functional point of view, they work together to permit the people to walk, to run, to jump. And we demonstrate that in all the people with chronic Achilles tendinopathy, there is also a thickening of the plantar fascia, because here is the thickness of the control, the plantar, and here the thickness of the plantar fascia in patient with Achilles tendon pathology. So some plantar fascia have a thickness that is pathological, a very pathological thickness. They have actually no symptoms in the plantar fascia, but they still have the thickening of the plantar fascia. From a clinical point of view, it means that we can't treat only the plantar fascia or only the Achilles tendon, but we need to treat all together because they affect each other also in the pathology. But changing the topic, I wanted to show you this 5 case report that we did to understand how we can work far away from the symptoms. In that case, we take a patient with a specific back pain and we decide to treat the patient far away from the trunk, so only in the inferior limb or in the superior limb, to demonstrate that if it's true the fascial anatomy, the continuity through the body, between the thoracolumbar fascia, the gluteus maximus, the ischiocrural muscle, and the calf. If we have alteration in the calf area, in the ankle, in the adductor muscle, the unbalanced condition between the two inferior limbs can affect the thoracolumbar fascia, and consequently the patient refer pain in the back, but in this case the thoracolumbar fascia is not really altered, but the receptor inside just feel the unbalanced tension. And in that cases, we have a huge improvement of the symptoms just treating far away from the thoracolumbar fascia. This could be useful also in patients that have a problem to be treated directly in that area because maybe have a major trauma or they have a too acute problem that don't permit a direct manual treatment in that area. But we can have also a mix between unbalanced tension and an alteration of the fascia. For example, here we can see a patellofemoral malalignment, and you can see the medial retinaculum of the knee and the lateral retinaculum of the knee that are the two fascial elements that create the proprioception of the patella that have a totally different tension. The medial one is very tensed and also thin. The lateral one is totally without tension and also is thicker. But I have found 3 different papers that demonstrate that inside such type of retinaculum there is also a changing in the innervation of the retinaculum. So I don't know what is the first problem. So is the alteration, that retinacula that have a wrong innervation are not able to perceive the correct position, the correct tension, and consequently they create such condition, or an unbalanced tension of the fascia day by day create also an alteration of the innervation. Actually, we don't know, but surely when we have a problem with a patellofemoral malalignment, we need also to take care of the fascia and the alteration of the tension and of the innervation. In another topic that I'd like to discuss with you is about the alteration of the gliding. In the previous presentation of Andrzej Pilat, you have seen in the cadavers how the fascia are important to permit the gliding. But here I'd like to present this study that for me was a masterpiece in the study of fascia that was published by Professor Langevin in 2011. She demonstrated as the thoracolumbar fascia the erector spina with the epimysial are not able to glide respect to the thoracolumbar fascia in patients with a specific back pain. But there is a lack of gliding between erector spina that are here and the thoracolumbar fascia that is here, around 20%. Again, this lack of gliding is well related with a lack in the range of motion, in particular way in the flexion and extension. But the same group of Professor Langevin then create a animal model and they evaluate such the ability of the thoracolumbar fascia to glide respect to the erector spine in the pig. Then they create alteration, in this case an immobilization, here a surgery, and in a third group both the alteration, so immobilization plus surgery. And then they checked after some week the ability of the thoracolumbar fascia to glide respect to the erector spine. And they demonstrate, as both in this case and in that case, there is a lack of gliding of 20%, the same that they found in the human with acute with a specific low back pain. But in the pig that had both immobilization and surgery, the lack of gliding was about 40%, demonstrating that there is a summation of the two problems. For our people, our patient, what it means that if we have a trauma, for example, ankle sprain, a surgery, and so on, and then we need to use a cast or other immobilization, we have surely an alteration of our fascia and above all in their ability to glide. So we need to take care also of that aspect. But the immobilization creates also a changing inside the muscle and in a specific way in the perimysium, as we can see here. This picture is well related with the picture that Professor Pilat showed you before in the patient with a spastic problem. But the last part, I'd like to speak about the research that we are doing in Padova about the hormonal component of the fascia. Because in literature we know that the female that have a different stiffness in the knee joint during the follicular phases and during the ovulation. In particular way, during the ovulation, there is a laxity of the knee and in specific way of the cruciate ligament. But again, there is other study that show that the people that use oral contraceptive drug have a cruciate ligament elasticity lower respect to non-user. So it means that the hormones are able to change our collagen fiber connective tissue. So we decided to check the effect of the sex hormone in our fascia. And we take some cell of the fasciolata and we create the stimulation in the lab with different level of estrogen to simulate the postmenopausal level, the follicular phases, the periovulatory phases, and the pregnancy level. And you can see here, as in both the case, we have an increased amount of production of collagen fiber. So it means that under a stimulation of estrogen, we have a fascia that is more active, that have a huge remodeling. At what type of collagen fiber are produced? We checked the collagen type 1, that usually is the most common collagen fiber that we have in the fascia, but you can see that it is not the collagen produced. The collagen produced is the collagen type 3, that is a collagen that has a totally different function. The collagen type 1 is the collagen that creates force transmission, is the collagen of the tendon. The collagen type 3, at the contrary, creates as a network, it creates a fascia that is more elastic, more adaptable, and that could be useful during pregnancy because it permits the change of the shape of the different muscles of the abdominal cavity, but at the same time reduce the ability of the fascia to transmit the force at a distance and to work as a supporter for the joint, for the ligament, and so on. We checked also the amount of fibrillin, that is the elastic fiber, and we see that in the periovulatory phase and in the pregnancy level, we have an increased amount of elastic fiber, also that create a fascia more adaptable, but less stable. What means that we need to know that data because in the different athletes, maybe sometimes we need to have a better elasticity, and consequently in the periovulatory phases probably we can work better. In other cases, that elasticity creates a lack of stability that could be also dangerous. But we need to know that also the diabetes can change the mechanical properties of the fascia, because we have many studies, but only about the plantar fascia, that demonstrate as the patient with diabetes type 1 have a changing in the production of the collagen fiber. We have an increased amount of collagen type 3 and less collagen type 1, and that create fascia that are have a totally different mechanical properties. They work a less way as tendon, and they are more adaptable, and consequently they can become also thicker and thicker to improve the ability of a fascia to transmit the force, because the collagen fiber are not the correct one. Finally, we need to remember that the aging can affect the fascia. We have only a study about the temporal fascia that demonstrate as in people more than 50 years old, the fascia is much thicker, much more resistant, stronger, and stiffer respect the fascia in the younger. So probably without a specific training, our fascia have a physiological evolution through towards a stiffer, stronger fascia that maybe from an evolutionary point of view could be useful to support our joint, but at the same time reduce the range of motion and create more rigidity in our body. So with that, I hope that I have given you some input to think more about fascia, and I'm available for some questions. Thank you.
Thank you very much, Dr. Carla. It's amazing what about the news about the fascia and how to know how is the fascia and about the anatomy and the physiology and how it involves in our leads in the sports. So thank you very much. Vamos a parar un minuto, cambiamos de mesa, ¿vale? Necesitamos cambiar la traducción, los técnicos nos ayudan a esto, así que en un minuto estamos de vuelta.
Okay. Thank you so much.
Bueno, pues continuamos con estas jornadas, esta última mesa en la que cierra las Jornadas Internacionales de la Lesión Deportiva. Es una mesa en la que participan grandes profesionales del sector de la salud en el deporte que están en contacto en su día a día con deportistas y cuidando de la salud de ellos. Es una mesa en la que, bueno, podríamos hablar completamente multidisciplinar, en la que vamos a ver muchos puntos de vista diferentes. Es un placer escuchar tantos puntos de vista diferentes, puesto que posiblemente
It's a pleasure to hear so many different points of view. That's how we can learn the most. Now we have a professional of great international renown, which is a great privilege to have this opportunity to work with him, and we'll also have a physiotherapist who's especially important, Dr. Jaime Salón. And David Rodriguez, who's a physiotherapist, and of course a great expert in training, which is Dr. Carlos Vasco Vorri. And so we're now going to start this round table with a speech on tendinopathy and anatomical links, and that's with Dr. David Ricardo Sanz. So thank you very much for taking part. It's a great pleasure to work with patients with you and to have this multidisciplinary approach with patients. Good morning. Thank you very much for this introduction, Sergio. It's a great pleasure to be with such great professionals. The interpreter apologizes. The sound quality is too poor to interpret. Okay, now I'm going to share the screen. I know you're going to be able to see my presentation. I'm going to share my screen now. So we're going to start with some general ideas, these associated anatomical variations.
David, ¿nos oyes? No se ve tu pantalla ni se te oye.
Well, we're having technical problems in the connection with Dr. David Rodriguez. So as not to delay things further, we're instead going to hear from the next speaker, which is Dr. Carlos Valsalobre. Carlos is an expert in physical training. He's a researcher in physical activity in sport. He's written a book on new methodological perspectives for sport and strength. He's a consultant for elite sport and for runners above all, in the and in NBA teams. And Carlos is going to talk about the new technologies for assessing performance and application in prevention and treatment of injuries. And so, without further ado, let's hear from Carlos Valsalobre's presentation. Okay, very good. First of all, it's a shame that David is having technical problems and that we've had to make this slight change in the order of presentations, but I'd really like to thank the organizers for this invitation. You're saying that you can't see me? Can you hear me? Yes, we can hear you fine, Carlos. Okay. I'm now going to share my screen. I'm going to put it in full screen. Okay. Right, as I was saying, I have a multidisciplinary approach in my involvement here in this roundtable because my main area is sports sciences. I'm a teacher for training and mechanics applied to training in the Universidad Europea de Madrid, and I've been very lucky to be a consultant for many elite athletes. I've worked a long time with runners. I've worked in professional football, in professional basketball. But I also have a great interest in the use of new technologies. And for a number of years, I've started to develop my own applications to work in areas of performance and improving performance and preventing injuries. So that's what I'm going to talk about in these 20 minutes. Now I'm going to put the clock. If you think I'm going too quickly, then there'll be plenty of time to ask questions, if there's any kind of questions you have. I'm going to start with something which I think is very important, and that is the paradigm of testing or monitoring. Why is that so important? Well, in team sports, it used to be typical to just do testing. We saw this on the television in the pre-season period. We did the number of tests on athletes. With constant, but in professional sport, we want to design monitoring strategies. And this has a different meaning because monitoring, its aim is to do frequent and systematic assessment to get as much information as possible on the athlete. Now, it means I'm less interested in how they performed in certain tests 2 or 3 months ago. What I'm interested really is to perform fewer tests, but to have more relevant day-to-day information and then I can access this information every week or even every day. Now, there are two main reasons for this. Firstly, to know if our training plan is working and if day by day or week by week if they're improving, and secondly, if we have an athlete with injuries, it's good to know what kind of values they need to be able to recover. If I've only got performance parameters from a few months ago, and then they have an injury, it's difficult to know where they need to get back to. But if I'm measuring parameters every week and there's an injury, then it's the value of the last week. That will be the reference value, the target, which I will try to get the athlete back to during the recovery process. Now, there's this famous model of return to play. And a lot of people from the world of physiotherapy, above all, are saying that before we return to play, there's return to perform, which is a prior phase. So to get to the same performance levels as before the injury, as a previous phase to before actually going back to playing and competing. Now, we've always used and we'll continue to use lab tech equipment, kinetic equipment, radars, encoders, jumping platforms, a whole set of technologies that are available on the market. But the fact is, with the advance of technology, we can measure more of these variables, not all of them, of course, but a lot of these variables that are often very interesting, just with a mobile phone. And what we see here on the screen, these are things that I just came up with at random. They'll have at least one you can see this is something that can be measured just with a mobile. Now, what I've really focused on in recent years are these four elements here, these four parameters, which is the jumping analysis, strength analysis, the sprints, running, and the movement range. And so to summarize, I'm going to present them in this short speech. So I'm going to start with jumping and strength, maximum strength tests. Now, I like to contextualize the importance of this strength training in this in prevention and in recovery. There's a lot of evidence, and I'm sure we all know this. Some of it, I'm sure, has been in previous speeches. Now, there's a lot of evidence of the importance of strength work in preventing injuries. For example, in this famous meta-analysis of Lawson in 2014, it was seen that the most effective training approach to avoiding injuries was to work on strength, basic strength. Now, I like, on this graph, there's proprioception here. Now, any movement, by definition, from a biomechanical point of view, requires strength and force. But when we're talking about base strength, we're referring to exercises that we know require a greater application of strength, such as bilateral movements, or a number of different joints involved at the same time, or on a stable platform on the ground. So weights and things like that. So now in team sports, at least in my experience, I'm sure you've heard this, that has been traditionally criticized and people didn't like doing that. People thought this was just for bodybuilders, power lifters, but there's more and more evidence of quite the contrary. There's some examples here. In this study, they compared relative strength, in other words, how often you can lift your own body weight, and they saw that the load ratio was lower the higher the relative strength was. Now, by having 3, 2.4, the higher the better, but more or less they're in this acceptable range. But then you see this big jump of going from 1.7 or less than 1.7. It's a very large difference. Now, the practical conclusion is that we have to ensure that the athlete, and this obviously has to be individualized according to the type of sport, the gender, the age, but we're going to try to at least have this margin of 1.7 times body weight in the dead weight, because that can protect the athlete. Now that might seem like a lot, but anyone who's done any kind of strength training will know that it's not too much. We're not talking about powerlifting, but if someone who weighs 70, for them to be able to lift one body weight, but we're talking about 1.7, so it's about 120 kilos lifting, and that's something that any elite athlete should be able to do without a problem. And any person with a bit of training would be capable of doing it. The problem is that sometimes we don't let them do it because we're scared that they're going to be injured. Now, it's probably because of a fear caused by poor progression. Now, normally if a person who hasn't been trained, in the first day I get them to do this, yes, then they certainly can have a problem or be injured. But if it's directed by a professional trainer who's qualified, then there shouldn't be any problem. And I haven't had any problem with that in my experience. Another thing are squats. This was published in the Journal of Strength last month, and they analysed all of the injuries caused by that occurred in an American team, and they saw that those who had the highest RM in squats were those who had the fewest injuries throughout the season. Also in the case of squats. And the cross ligament injury, they've shown that those who had the greatest strength in the squat were those who, in the drop jump test, had the lowest adduction of the hip, and so the authors concluded that it was associated with a low risk of damaging the ligament. So that's why it's so important to work on strength with a number of different strategies. They don't all have to be heavy squats. This is when we need a lot of strength and of slow, but in other cases where we need faster movements but lower weights. There are other cases where we just need to do exercise with very little weight but faster, or super speed. Now, it really just depends on what the athlete needs. Some are more deficient in speed, some are more deficient in strength, but all of this requires an assessment to just see where they are. They need proper training. And if they're injured, what value we need to return to. So, for example, in the case of vertical jumps, the standard devices are strength platforms, the contact platforms. And so they measure the height of the vertical jump. And this is just based on hundreds of year-old processes, Newton, and they calculate the height just based on the amount of time that the person is in the air. Now we can do that with just a simple mobile device. The best known, the oldest app here allows you just to film the athlete jumping, and it detects when they leave the ground and when they land. And that creates a time value, and that time value is turned into a height. Now, this was done an initial evaluation a few years ago. I think there should be 8 different assessments around the world, and they all go in the same direction, and they see a very strong correlation between the strength in laboratory and a difference that depends on the device used to film. Now, when I did the original assessment, the mobiles only had 120 images per second. Now it's 240 per second, and so that leads to a difference of 4 or 5 millimeters in the height. So it's important to have now the apps are better in that respect. So, what about loads, heavy loads? Technology is trying to solve a major problem in strength training, and that is, how do I decide the training load? Now, typically, the training load we've decided according to the 1 RM. The problem is that that's so intense that not all patients can do it, and not all healthy people with low levels of performance can do it either. So, even if they're very well trained, like powerlifters, these values of 1 RM change every day. So if I want to train according to this RM, because the way that you program strength training is that, well, you start with 3 series at 70% or 80%, or 3 series at 90%, and once I know 90%, I'm close to 100%. And because this 100% changes every day, I need to do a test of 1 RM every day before training. Now, as you imagine, this is very, very intense, and this can't be done. I wouldn't want to do that. So there are indirect strategies. The indirect strategy, the best one that we have, is what we called low velocity profiling. And there have been studies that show that there's a very strong correlation between the speed at which I lift a bar, or that I do the squats or the bench, and the percentage of the RM which I should lift. And so if I measure the speed, I will be able to estimate what the 1 RM of the sporter is without having to get them to do a 1 RM. And to measure this speed, there are a number of different technologies that can do that. The best known one in training is the one you have at the top, which is this sort of box which has a harness, and that's a cable that you attach, and that measures the speed. And then there are more new ones, such as accelerometers and a movement camera. And my solution is more simple and more low cost, because the encoders, the cheapest ones are 400 euros, and the most expensive are about 3,000. So these professional measurement devices are quite expensive. So the application, the one I showed before, it just costs 10 euros, and you can for the iPhone and Android. So it's much simpler. And what this application does is you record the patient lifting a weight, and it records the lowest point and the highest point, and that allows me to measure the velocity. And then I use some linear equations. It's all integrated into the app. The user doesn't need to worry about this. It's done. Everything is done by the application, and that estimates your 1 RM for every day. So, for example, if I move 150 kilos at this speed here, 1.1, and then it's 102.6 kilos. Tomorrow, instead it's 1.1, it's 1.05 because I'm a bit more tired. Then the application will say that my 1 RM today is, I don't know, maybe 90 kilos. That's the most precise way we have, at least from my point of view, to estimate the 1 RM in the best possible way without having to do all these tests. So there's a laboratory and professional encoders that were compared with it, and they said that it seems to be very, very good. Now I'm going to move on to the next section. I know I'm going quickly, but I want to keep within the time that we have. I know that we're a little bit behind schedule. So now I'm going to talk about the analysis of locomotion, walking, both walking and running and sprints. So it's interesting to analyze the mechanics of running, because it allows me to see the technical qualities and to analyze any possible asymmetries between limbs and to get reference values for when the athlete is injured, so that we know what levels need to return to. So generally we can analyze kinetic factors and study the forces and kinematic elements. Now in kinetic things, one parameter that's very interesting and is related to the tendon, related to stiffness. I like to put this video when we see the 100 meters sprint with hurdle. Here's a perfect example of a runner with a very stiff tendon. Now, from kinetics as well, there's another thing we're interested in measuring, and that's what they've seen that the pelvis of the runner is very much related to all of the most common injuries of the runner. In this study, they measured a whole load of angles and variables, and they show that those athletes that had levels of about 6 degrees or more were at a greater risk of suffering femoral injuries or in the tibia or in the Achilles tendon, Achilles heel. So that it is correlated with a risk of injury. And here is a kilogram. And they do that in Altis, which is probably the highest authority in sprint techniques, and they understand the issues of the torso, the knee, and the heel that are measured here. And so we use force platforms here and reflecting cameras, and so there are a number of things we can measure now just with the mobile phone. This is an application called Ironmatic, which is one of mine, and so you have it's a slow motion. And so it can detect contact with the ground, and we can see that there is a correlation of 0.95 compared to a platform that gives the stiffness values, contact with the ground, the asymmetry between legs. Now, regarding not so much with running, but with the tendon, the Achilles tendon in this case, there's a very recent app which I developed, but it was Kim Herbert's idea from the University of Waikato, who works a lot with the All Blacks, and works a lot in rugby, and she was very interested in doing a clinical assessment of the Achilles tendon. And so it records the movement of a point that we mark on the heel. And this allows us to measure all of the repetitions, the height reached, the power, and the work. Now, you don't need any equipment, you just need a mobile phone. And finally, just to end, regarding the movement range, there are a lot of joints, and we could talk about a lot of them for many different roundtables, but basically, we're going to talk about 2 movement ranges that we're going to that are significant to prevention, and I'm going to talk about one of them, which is the movement of the heel. Now, there are 2 mechanisms here. There are often 2 types of injuries in the hamstring. We know that it's in the last phase of the swing that you're most likely to be a hamstring injury, because it's for when they have to decelerate and then move. Now, it's not the only strategy that's used to prevent these hamstring injuries, but they're very popular because the eccentric flexion has been shown in a number of studies that it prevents injuries. Here we have an example with football players, and where they were given, they said they saw a significant reduction in the risk of injury of 3.8 for each 100 of the ratio. Those who didn't do Nordic. The problem is that we didn't know how to quantify it. You told them to do Nordics, or was it 3 series of 8, 3 series of 10? It was a little bit subjective. However, in this 2015 study, they showed that there is a strong relationship between the levels of the torque and what they call the break point, which is the angle at which the athlete is able to maintain in their knee just before falling in this Nordic exercise. So in this context, we designed this application, was called Nordics, and that's what it measures. You see, when they take their hands off of their chest, that's when they're falling, and you measure that angle. So we put some values into the profile of the weight, a number of figures, and so using basic biomechanics, we're able to measure the maximum torque of this patient. And finally, the last variable that I like to measure is the dorsiflexion. As you know, there is a strong correlation between dorsiflexion and the increased risk of lower limb injuries. It's known that dorsiflexion does significantly change the mechanics of landing. That's what happens in this jump. You see that the compensatory mechanism of the knee is what can actually cause damage. So generally, we've measured it with the famous knee-to-wall test, and even more basically with a meter. But if you've got two different athletes who've got this exactly the same dorsiflexion, but one of them has 45 and the other one has 51, and that 51 one is going to be closer to the wall. So the measurement is very imprecise. We have to measure the angle, and so that's we need the goniometers. Now there's the last app that I'm going to present, which is called MyROM, which allows us to measure the angle, not just for the dorsiflexion, but originally it was designed to measure the dorsiflexion. But in the end, what we did was, well, you just put the iPhone on the tibia, the phone on the tibia, and the patient bends forward, and there's a counter, and you get the result. And we compared this dorsiflexion value with a professional laboratory equipment, and there was a 0.99 correlation compared to the angiometer, and it's an app that in physiotherapy tends to work very well. Now it's a great honor that elite clubs are using these applications, and also because it's very easy to use an app like this, that it's being used in areas where it's difficult to get high-level equipment. So they don't have these sort of platforms all over the world, but everyone has mobiles all around the world. I'd just like to end by contextualizing where we come from, because not so long ago that we did assessments in a rudimentary way, as you can see here. And yet now we can measure a lot of things, not everything. But what I measured in my doctoral thesis in 2012, I couldn't do now, and just with my mobile phone. So that's all for me. I hope I haven't gone much over time, and I hope that you've been interested and you found it. You enjoyed my presentation. Here's my contact details if you have any questions. This might occur if you don't have a question now, but you have a question in a few days' time. So that's all. I'd like to thank the organisers. I don't know if there are going to be any questions now, or if we're going to leave it to the end.
We're going to carry on with the next speakers, actually, Carlos, and once we're finished with the remaining presentations. We'll move on to the Q&A session. So, Carlos, thank you very much for your presentation. Once again, thank you for talking to us about these technological advancements in the world of sports, and thank you for putting everything in the context of sports injuries. So this is the final round table of this international event. I'm very happy to introduce you to Dr. Manuel Leyes, Director of Leyes Progresos Asociados, consultant traumatologist at the Centro Clinic. Is cooperated with a number of football clubs, including Real Madrid Football Club. But generally speaking, Dr. Leyes is known worldwide as a sports traumatologist. It's an honor to have him join us today. Today, he'll be talking to us about the pitcher's shoulder. I'd like to thank Dr. Manuel Leyes in advance for everything he'll be sharing with us today, and I'd like to take this opportunity to thank him once again for joining us. Hello, Sergio. It's a pleasure to take part in this event. For me, I'd like to congratulate Carlos because I truly loved his presentation. It's unbelievable what you can achieve with a smartphone. Thank you, Manuel. I'd actually muted my microphone because I didn't want to bother you, but I just wanted to thank you. I'm looking forward to hearing more from you in your presentation. Thank you.
No sé si se ve la pantalla.
Perfectamente.
Yo voy a hablar del hombro del lanzador que agrupa.
So today I'll be talking about the pitcher's shoulder. It's actually a group of painful disorders with quite varied etiology. They're all related to the movement of pitching. A few years ago, after I was done studying, I went to Cleveland and I worked at the Indians, a very important baseball team, and we had a lot of problems with pitchers, shoulder problems. When I came back to Spain, I worked with Cesar Flores, handball, female handball physiotherapist. Sorry to interrupt you, Manuel. On the top right, there is a Skype window. If you could just close it. Okay, great. Thank you. With Caesar, we worked with a lot of handball athletes who had experienced similar symptoms. I can't get past this slide, it would seem. I apologize. Try clicking on top of... Oh, there we go. What do pitchers have in common? They'll put a lot of strength into their shoulder movements, and these shoulder movements are very repetitive. Their mobility arc aren't particularly wide. In baseball, especially, the quality of a pitcher is measured by how fast he can pitch. Over 168 kilometers an hour, that's a very good pitcher. In handball, balls can reach up to 123 kilometers per hour. In tennis, 263 kilometers an hour. So very, very high speed. This gesture is very similar for all of them, this movement. High external rotation, And the speed at which they're able to pitch is closely linked with this rotational range that they have. Another group of gymnasts where we get similar diseases are gymnasts. Gymnasts need to be very elastic, a lot of external rotation. So the disorders they suffer from are similar to the pitcher's disorder. Pitching repeatedly, of course, ends up increasing the capacity for external rotation. A good pitcher needs to have a wide rotational arc. It can't be too rigid, but exercise can actually increase this capability. A study published by the Professional Baseball League observed that external rotation increased by 5 degrees by the end of every season. What happens when we rotate externally? We put tension on the interior band of the humeral inferior ligament. This happens in phases of late cocking and early acceleration. This continued movement stretches out the collagen fibers and increases the external rotational capacity of pitches. An aspect that is common to all of them a physiopathological aspect is the loss of internal rotation in abduction due to the emergence of contractions or fibroses of the inferior humeral ligament, the rear band. Why does this part of the capsule get worn down? It's because in the follow-through phase you have to halt the movement, and this capsule resists the tension of the arm, and this movement, which entails repeated tension, eventually creates scar tissue in the rear capsule. A lot of articles have shown that tennis players, baseball players, handball players, etc. are all affected by this, a loss of internal rotation capacity due to fibrosis in the rear capsule. But this is quite easy to detect. Very often, when athletes come to my clinic, they beat about the bush, however, and we have to diagnose the disorder ourselves. This is a very extreme case. His external rotational capacity is extreme. However, his internal rotational capacity is impaired. Again, this is easy to detect because it's not a subtle loss of rotational capacity. A study that was published in the year 2000 estimated that the average in this loss is 53 degrees. So it's very easy to detect. What happens when the rear capsule becomes contracted? We change the rotational center of the humeral head, which would normally be in the naked point here at the center of that area that you can see on screen. And when it becomes contracted, and as a result we develop fibrosis with a shortening of the rear band of the humerus, the head is displaced towards the back, and the rotational focus is also becoming displaced as a result. So the arm rotates over that axis. The head of the humerus is pushed back, and the biceps of the tendon in late cocking creates a slap injury, which is when the extension extends, sorry about the repetition, towards the rear of the capsule. That's called positive peel back. So this is the mechanism. There is a contraction in the rear capsule. The focus of the rotation is displaced, and eventually the joint comes out of socket. Lots of academics have estimated that during the phase of follow-through there may be a degree of traction that ends up ripping the joint off the socket, but in my opinion this theory doesn't make a lot of sense. This is a video of a peel back. As you can see, the biceps is starting to tear. So this hasn't completely torn off yet. It's been caught in time. But in the case of a slap effect, as you can see here, well, that needs to be fixed, that needs to be repaired. So early detection of loss of internal rotational capacity is important. If you can correct that, the athletes won't need such slap reparation. After the biceps disinsertion, the head of the humerus starts ascending, and along with the twisting, eventually breaks the socket. This is important because the general population believes that the rotational cuff can tear through rotation only, but that's not the only reason. Through chafing only, you can't get the joint to break. Pitchers with a slap injury, 62% of them have a partial rupture of the cuff, 38% experience full rupture. The percentage of the cuff that is affected is also an important factor because as far as the surgery is concerned, if less than half the cuff is affected, there will be a loss in stability, of course, but nothing else. If more than half the cuff has been torn, you need to intervene and you need to repair that. So the physiopathological cascade is this: contracture of the capsule, displacement of the head of the humerus, slap effect, peel back, and type 2 slap injury with eventual rupture of the cuff. These are a few examples of the several stages. The capsule here is very, very thick, the rear capsule. The bicep is torn here, and the joint fibers of the cuff have started rupturing. This triad is found very, very often in this group of patients. To give you another example, this is a case of early detection. So the capsule is isolated, slap lesion, but for the moment the cuff is doing fine. Similar case, this slide, on the other hand, well, this case is actually identical to the previous one, but the labrum is also torn here due to an excess in external rotation. This is a gymnast from the Spanish team with the same exact lesion that a handball could have suffered. Displacement of the biceps and damaged cuff. Another problem that is often found in pitchers is the so-called internal impingement. We call it that to differentiate between this and subcolonial impingement. There are two types of internal impingement, posterior superior and anterior superior. Posterior superior causes the fibers of the cuff to become trapped between the upper ridge of the socket and the lower ridge of the socket, so they compress it. They compress the cuff and further damage it. This is an arthroscopy. Look at the abduction, external rotation capacity, and look at how the tendon comes in contact with the lower part of the labrum, thus damaging it. It's important to address this because by solely repairing the labrum and the cuff, you won't solve the problem. You need to fix the instability problem with the shoulder. This is an MRI where you can appreciate how the subspinal fibers have become trapped between the upper ridge of the joint and the lower ridge. Another type of impingement, which is more frequent, is anterosuperior. It affects the front part of the shoulder and part of the bicep as well, the pulley and other ligaments. So it's a frequent injury, this one. These are the coracoids, and as you can see, the subscapular area is also affected. We've operated on a few paddle players who had this problem. They develop it when they do a cross drive. They damage the tip of the coracoids in the subscapular area. Regarding treatment, I feel ashamed talking about traditional treatment in front of such important physiotherapists, so I'll be mostly focusing on the surgical part. The conservative treatment is aimed at restoring dynamic stability in the shoulder, with a view to ensuring that throughout the movement arc, the center of rotation of the head of the humerus is as close to the socket as possible. It's very important to maintain this mobility range in these athletes, and that's why this disease is particularly complicated, because if we're working on a picture we want to stabilize the head of the humerus, but by doing that we reduce mobility, we've just destroyed their sporting career because they won't be able to pitch as fast. It's very important to do some strength training to strengthen the glenohumeral and the scapulothoracic muscles, as well as the muscles of the torso. Now, a fashionable concept here is total motion, whereby external and internal rotation of one side would be summed up and then compared with the sum of the other side. And through physiotherapy, we strived to recuperate a value that would be similar to total immobility. Now, if we detect this early, all we have to do is stretch the posterior inferior capsule, which is a very, very simple sort of treatment, but yields great results, and lots of studies have shown that this is effective as long as the problem is detected early enough. A study that was done in 1996 on a number of tennis players that throughout the season would get injured, but then after the intervention of the physiotherapist would get injured less often. This is a marvelous physiotherapist, Ángel Basas, and this is Mercedes, Spanish champions in javelin throw for 9 years in a row. She dealt with a bad injury for a long time, but she kept on throwing. She broke the cuff, and the broken cuff would only allow her to perform one throw at a time. She couldn't perform two in a row. She wanted to break the national record for successive championships won, and she did break it, but only No, sorry, she didn't win the gold medal. She won the silver medal, precisely because she could only perform one throw. About strength, that's not something I'll be talking about in detail with you, but these are the areas we mostly focus on: neuromuscular control, and then let's talk about surgery, surgical treatment. Surgery is truly the last resort. We'd rather not have to perform it on an athlete because very often a normal patient would, surgery would work on them, but for an athlete, fixing the head of the humerus while maintaining the same mobility range is complicated. So what we do is, when we're forced to intervene surgically, we compare one shoulder with the other. Mind you, these aren't the typically unstable shoulders. They're different. So there are several things you have to look for, subtle signs: stretching capacity of the anterior capsule, fibrosis in the posterior capsule, PLB lesions, labrum lesions, interval value, MR, ABER exploration, arthroscopy, with internal impingement. By simply correcting instability factor, it has been shown it is possible to get rid of pain. So this is a surgery done arthroscopically, and these are the associated processes: to liberate the posterior inferior capsule and repair the biceps as well, stitching up the labrum and fixing the head of the humerus, repairing the cuff as well if more than half of it is torn. The final goal is to center up the head of the humerus without losing any mobility. I'll give you a few examples to show you how complex this is. This is an elite player, an elite handball player for the Spanish national selection. For the Brazilian national selection, captain of the national selection. He came to us with sharp pain in his shoulder, typical pitcher's shoulder. Look at his bicep ligament. Look at the damage here. A non-competitor, we would just cut this off. But the biceps is important in proprioception, and if you cut it off, so I have to do something with it. The cuff is starting to tear. This was a difficult surgery because we started removing the fibers that were closer to the tendon, and the result was, well, this tendon that seemed reasonable. So this athlete, thankfully, is already competing at a good level. We also had to fix the issue with anterior instability, look at the laxity of the capsule. We had to bring it back up and stitch it up with the labrum to center it up as well. And finally, we fixed the cuff. This is not too difficult for a shoulder surgeon. It's a mechanic intervention. I think the work that is carried out by the physiotherapist is more important here, because all patients scar in a different way. Some patients you have to work with a lot, and other patients you have to curb their enthusiasm to return to play. Otherwise, they risk doing more damage. In the case of this Olympic gymnast, look at his bicep. It's literally irreparable. if we do sever it, it's going to lose power, however. So what we did was athenodesis. We drilled a hole and inserted the bicep into this new hole. Also worked on the posterior capsule, which was contracted. It's a fun surgery to do. If you're experienced, it's not very difficult.
Now, you have to be very careful with these instabilities because they're subtle instabilities. They're not manifest in the shoulder. You never see it, but if you don't do anything about it, it destroys the shoulder. Look at these the movements here. They can completely destroy the cartilage. So for us, this is a silent enemy. Now, sometimes it can be too late for the patient. This is what I want to say. Now I'm going to promote a little bit our account, which you can, we put up every week. We put up cases from our day-to-day experience, and so I'd just like to thank you and say once again that I'm really happy to have been able to participate. Manuel Elias, thank you very much. It's a great pleasure and a privilege. We thought that we were going to be able to continue to learn with what you had to say. Yesterday we started to talk about this objective assessment, this functional assessment that needs to be done on movement. Dr. Andrzej Pilat started to talk. And now to finish this workshop, you went in with some great professionals here. And as we can see, it's very much multidisciplinary work. So I really encourage everyone to work in a multidisciplinary way in teams. That I've said this before, but it's the athlete who's the real protagonist of all of this and should be at the center of everything we do. So there's this mix between structural recovery of tissue or function. They're very much complementary. We can't do one without the other. And the psychological issue is important as well. But people are we're people before athletes. So thank you very much for sharing all of your knowledge. Thanks to you. Thanks very much. Now we're going to continue with Dr. Rodriguez Sanz. Now that we've managed to sort out all the technical problems. So David Rodriguez, as I said before, is a physiotherapist and podologist. He's going to talk about the Achilles adenopathology. So I think he's going to provide very much a multidisciplinary approach, and this is essential to look at these clinical cases in the best way possible, alongside these physiopathological aspects in terms of performance and function, as we've heard earlier this morning. So, David, it's a great pleasure to have you with us. It's a great pleasure to talk about these athletes together. Thank you. Thank you very much. So sorry about the technical problems. We did some tests, but I don't know what happened. I'm sharing the screen, am I?
¿Dónde pone detener? Un poquito más a la derecha, debajo de mi foto. Perfecto. Estupendo. Perfecto, pues David. Fenomenal, muchísimas gracias. En primer lugar,
That's great. So thanks very much. So first of all, I'd like to thank all of the previous speakers, Dr. Leis and Salobre, who gave some great presentations. And I'm now going to share my screen to start.
creo que ya empieza la pantalla a estar compartida. Así es. Eso es, fenomenal. Y vamos a por ello. ¿Me escucháis bien? ¿Me veis bien? Adelante, David. Muchísimas gracias.
Go ahead. All right. So we're going to talk about the Achilles heel. I'm including this this Rubens painting here. It's a Flemish artist. He was an anatomist, in fact. And he was the first anatomist who wrote about the Achilles heel as such. Below you can see my affiliations, the Complutense University of Madrid, and of course my LinkedIn and Twitter information in case you have any questions. This is the Achilles tendon. It's the most powerful one in the body, and it's about 15 centimeters in length. Its anterior surface, as you can see below, is made of fibers. And one of the things that I like to draw attention to in the lower image is all of these structures that we see from the Achilles tendon, the soleum, the flexor, the fat, the retrocecal bag. That there are a lot of different structures in a small space. On the left, we can see the fluorescent image of the tendon where it connects to the bone. There's a double vascularization, and one aspect that I'd like to draw attention to is this double vascularization, both in the tibial artery and the peroneal artery. And you see this green area here that has lower vascularization between 2 and 6 centimeters from the insertion. All of those who've had patients with the difficulties here, they've seen that a large proportion of those who have Achilles problems is often associated with this precarious vascularization at this point. Now you've got the sural and posterior tibial. Now a double vascularization requires some coordination. Now, within epidemiology, we see that most injuries, a lot of them affect the Achilles heel, and a lot of them go to their GP for this. Now, there's a number of different levels of damage, but we're going to focus on inflammation, asomatic inflammation, mucoid degeneration, and yellow or brown tendon. Chronic inflammation with degeneration in the substance because of a failure of the matrix, cellular matrix. Then there's a kind of triad of angiofiblastic tendinosis. And in this triad, we have an increase of fibroblastis, vascular hyperplasia, and collagen disorganization. Now, I'm not going to go into much more detail here because we've heard this during the workshop, but we can see that there is a component of a normal tendon that can become degenerative, or according to the phase that we're in, and it is the main modulator is the load it receives. And we've heard this during the workshop, and it's interesting to see how these different components can help to manage this load. Now, in Jill Cook's next publication on the left, we see the various different elements where there's which cause pain or problems in functionality, or good functionality without pain, we see all these different procedures where we have to manage the load or limit it in order to protect the tendon in these phases. Well, why is this? Well, if you look at the screen, we can see the collagen synthesis and how it's very much related to the load. So it's a kind of like a vaccine, if you were. So this then increases until it stabilizes. It's also important to say that neutral collagen is regulated independent of the type of contraction, and it's not, as we've seen before, the tendon adapts better to intensity of stimulus than volume. So it's important that we introduce that in how we manage our patient. Just as we've seen that the number of attempts often doesn't give us so much differentiation in terms of the tissue as the intensity and the speed of the movement. Now, associated factors with tendinopathy, we've got intrinsic and extrinsic factors. Now, we have to control a lot of factors so that the patient can get better. Now, the biomechanical components, there's the position and mobilization of the subastrogaloid joint. That's very important. There's the we can do a Coleman test to look at the back foot. That's very important, the back foot. And one of the most severe things associated with the Achilles tendon is related to the back foot. Then, of course, there's the knee and the tibia. So you see that there's a lot of things that are associated in the pathology. And the more these can be controlled, the more chance of success there is. The more information we have and the more tools that we have, the easier it is to avoid tendon damage and the better the state of the tendon. Now, these are the clinical signs for diagnosis. So we have to do pain at palpation upon touching, and then there's a pain at initiating activity, and often it can descend during activity. The pain often falls during activity. Then we need to, sometimes we have to suspend the activity. This can often increase rigidity after a time without movement. There's histological changes, and in the end, tendinopathy is about a disorganization in the collagen, an increase in the metabolic qualities. There's a reduction in oxygen. Now, in the Achilles tendon, the oxygen diffusion is not very high because there's only a few fibroblasts that receive the blood. And now we're going to look at the management through image diagnosis. Ultrasound of the musculoskeleton system is really the most important thing, the MRI. But there's also the MRI, as I said. And then there's another one which is not exactly diagnosis, which is thermography. Now this leads us, our research group, to develop different objective assessments. We've had a number of publications, as you can see on the screen. Physical Therapy in Sport, Journal of Clinical Medicine, and talking about this assessment through thermography, both in runners and in football players, associated with this kinetic or functional aspect. Now with the thermographs, we looked at ordinary patients and patients with the problem. And we can see that when there's electromyographic assessment, there are two publications on the use of different shoes. And we can see there's certain ones that can predispose towards an injury. Now, we want to initiate some research on the use of sporting shoes like football boots. There's one particular type that damage the Achilles tendon a bit less, whereas the Antiporo or Nike Ligan 7, they protect the tendon much better. So when sometimes we saw that athletes had the wrong shoes, and that was very interesting. And as Professor Azaloberto said, there are a lot of publications here on the pressure platform, and the pressure and the speed of the pressure in the back foot are key elements in managing this in order to protect these individuals with tendinopathy. Now we've seen that the Achilles complex, there's a lot of elements here for a lot of types of illnesses here. And so we found a number of different ultrasounds in different areas to see what differences we found in patients with tendinopathy and compared to those who didn't. And this is in publication. This is from last year. It was published in Physical Therapy and Sport. And we compared the Achilles tendon between those with a problem and those without. And one thing we saw was the angle of the and we saw that the angle is very important because this makes the muscle less effective. Then there's an increase in the thickness. An increase in the thickness of the transversal section from 4 to 6 centimeters of the insertion. But one of the things that really drew attention was that it reduced the length of the carga fat. Now, a structure that is not intrinsic to the tendon is doing this, and that's interesting. Now, we saw this as a risk factor, which increases the likelihood of tendinopathy. And here we see, as you can see on the right-hand image, how, according to the movement, the carga fat changes. Here on the right you see full dorsiflexion. You can see how it goes beyond the limit of the Achilles, and then plantar flexion. This is very important because it's an excellent way of dosifying, protecting the tendon. And so if it has the right size and it moves well, it's going to protect the Achilles heel. Now this is something we can see easily in an ultrasound, and so it's very an interesting approach. On the other hand, there were some changes in the deformity, but also in the behavior of mechanical processes. Now this is associated both with functionality and also to the clinical symptoms of the patient. Here's a study with this helps us how both the mechanical capacities predict what's going to happen. This is something we expected, but if you have an Achilles tendinopathy and there's this one component that's associated, which is very close, which is also related. We continue to do ultrasound to see what we found. This is what we found. We saw that the plantar fascia in these patients we saw that the thickness is reduced with patients in tendinopathy. And also the thickness of the fascia is also reduced in patients with tendinopathy. So it doesn't just affect the tendon, it also affects the kaga fat and the plantar fat, and it's also affecting the plantar fascia. Now, a year before, we did this study on the plantar fat, and we saw that the patients that had pain there, they often showed a reduction in plantar fat. And this is in a publication in Pain Physician in 2019. And here you can see that normal values compared to the ROC curve. And these are values that are important so that the patient doesn't have this pain. And so we found a few millimeters above or below to this 0.915, and in women 8.15. Now these are values that we get with the probe, as you can see on the left. This helps us to understand things a lot, because sometimes we want to do these objective tests and you can see what is happening, and we want to be as objective as possible. So we don't just do pain assessment. Now we're also doing research, and we started to analyze the intrinsic muscles of the feet, and we published in Physical Therapy and Sport, and our research group saw that there's an increase in the transversal section, and there was an increase in the thickness of the flex, the short flex. Now this shows that the Achilles heel is not working very well, because there's an tendinopathy and the kaga fat might not be optimum, and so there is a compensatory element by the flexing muscles. And when we did an ultrasound in these patients, and from the posterior to we saw that the most posterior part was the Achilles, the tendon, and at the end it was the tibia. And we saw that because of this lack of functionality in the Achilles tendon, it was associated with an increase both in the transversal section and the thickness of the flexing muscles. So what are we seeing then? We're seeing that at the beginning we thought it was just a pathology in the structure of the Achilles tendon. We've seen this in the kaga fat, in the changes in the plantar fat and the plantar fascia, and in the intrinsic muscles of the foot. So we continue to study a bit more to see what other changes there are. We looked at the extrinsic foot muscles, and this is something that was published a little bit afterwards. And here we saw that the thickness of the anterior tibia was increased, and there was a reduction in the transversal section of the intrinsic muscles of the feet, which predominate in the stabilizing the knee, so the heel. So it's an illness that is one particular structure. We're seeing that it's affecting many other structures, and this was very interesting. But beyond this study, we decided to look at it a bit further, and so we went to the abdominal wall, and we saw that when we look at patients with tendinopathy, this was affected. Here's a publication which is in Diagnostics just a few months ago in December 2019, and what we see is that there was an increase in the thickness and the transversal sectional area, an increase in the interrectal area in the abdomen, and a reduction in various other areas. So an illness which is in the foot is intimately related to structures that all the way in the colon and the abdomen. So once we've done this first section, we decided to start with experimental models. And so we include eccentric programs associated with vibration, and one was associated with cryotherapy to see what could be done with these patients. We saw that there's an old image there. We've been doing it for a while. There is a player who's already retired, is Luis Bueno, from his time in Real Madrid. And he's working on a vibrating platform. And here he's performing various different actions within the vibrating platform. And what did we see? We saw that when we combined with the vibration, there was an improvement in these patients. So that is very interesting, to have a tool which is relatively simple, both vibration and cryotherapy, that can, we saw that vibration improved the transversal section of muscles in these areas. Now we compare different techniques because, of course, we have to compare. We compared the eccentric and the vibration and the Achilles tendon versus the eccentric and cryotherapy. These are the results. We saw that both of them improved to 0 to 2 or 4 centimeters. The state of the Achilles tendon, which we can see at rest in the graphs on the left-hand side, but there was an improvement in the movement with vibration in the cross-section area in patients with cryotherapy. So when we have a greater impact on the Achilles tendon, when we do the eccentric treatment, it generates an improvement. A couple of minutes? Okay, very good. On the other hand, we also added this comment to analyze the muscles of the core, and we see that the vibration helped us to improve the fitness in patients with these components of cryotherapy with vibration. Just to give you an idea of the conservative management of, well, this is what we found. There's a safety zone between up to about 2 and 3, and there's an acceptable area which can be up from 2 to 5. And then when we do the assessment of the patients, it's interesting to see a range of the strength and resistance and the jump. So these are all tools that we use in the study. And this we saw the morphological changes, and we see how the therapeutic exercises were most recommended, and that we could combine them with other structures. Here's a publication that has been talked a lot about in the study, and it talks about this limit for working on the eccentrics with the patients. Now, this is very subjective. This is an old publication. Sometimes it's concentric, sometimes eccentric. Now, this is very, very subjective, of course. So if an athlete has had a good day or got some good news, they'll evaluate their pain differently. So the proposal that we made was to add these objective assessment factors. So that is ultrasound or the use of the pressure platform. In conclusion, it's very, very simple. Now, there's a lot of articles, a lot of research here, but this is the take-home message. This is a question that all the clinicians have received. If my tendon is okay, why does it still hurt? Well, the thing is, there are lots of pieces to the puzzle. It's not just that the tendon is okay or the good or right. It's that the chaga fat, the flexors, the plantar fat, the plantar fascia, the core, the intrinsic muscles, the extrinsic muscles, all of these might not be well. So there has to be evaluated just as we evaluate the tendon, Achilles tendon itself. And then there's the load progression, the use of objective tools. Here you can see how that load increases. I like to have the metaphor of the microwave. And a microwave at home has 3 different positions. When I put a coffee in the morning, the first one is that the coffee stays cold. And then I can get it kind of warm, but then if I increase it a little bit more, I don't know if this happens at home, which is just like volcanic lava. It's too much of a jump. And then we have this problem with dosing. And so we have to find this way of dosing it gradually. Sometimes we get it right, sometimes we don't, but we have to be very, very careful with how we manage loads. On the other hand, there's a whole set of different types of Formula One wheels, and we need to adapt to the different situations. We have some boots and shoes that are more appropriate to different situations. Now, if I use just one element for the soles, then I will only be able to cure one type of patient. So we have to adapt the type of mold, the type of material that's used. If you just use the same material all the time, we'll often get things wrong. We have to adapt to the type of shoe, the type of activity, even the type of training that's been done. The training is not always the same. We have to adapt to all of that. And to conclude, there's a phrase. There's a chess grandmaster, Kasparov, says, if you don't correctly assess your position, you will make the wrong move. So it's very important to optimize both functionality, both of the core and of the feet and the ankle, both in terms of movement and stability. So thank you very much. Thank you very much.
Thank you very much, David. It's been a pleasure to learn more about the multidisciplinarity of the approach to curing tendinopathy. Not only that, but also the function of the various different elements, the loads, how important the contribution of physicians, personal trainers, and physiotherapists is. So a truly cross-cutting approach to limit the incidence of tendinopathy and how to treat them. So thank you very much. Thank you. There are lots of structures that become damaged so easily and we can't treat them all. It's difficult to put out these fires. Let's carry on with the final talk. The final session of this event, featuring Dr. Jaime Salón, a great expert in physiotherapy and adaptation. Is physiotherapist for Real Madrid CF, lecturer at the Francisco de Vitoria and Juan Carlos I universities. So without further ado, let's begin. David, I think you have to stop sharing. Thank you.
Hola a todos, mi nombre es Jaime Salón Moreno, soy fisioterapeuta, profesor de la Universidad Francisco de Vitoria de Madrid y actualmente trabajo también como fisioterapeuta en los servicios médicos del Real Madrid en su primer equipo. Antes de nada, quería agradecer al comité científico la posibilidad que me ha dado de participar en esta jornada. La charla que voy a dar está titulada Bases analgésicas del ejercicio terapéutico. Antes de nada, me gustaría aclarar que cuando hablamos de ejercicio terapéutico lo vamos a hacer encaminado, como bien nos dice la RAE, hacia todo aquel conjunto de prácticas que van a estar encaminadas al tratamiento de una patología. Es decir, la parte de la medicina que nos va a enseñar preceptos y remedios para
and there's physiotherapy on the other, but there is a difference between therapeutic exercise and there are, on the other hand, processes that are associated with treating the symptoms.
Por todo ello,
In order
es
for us
necesario
to
que
talk
exista
about
para hablar de
therapeutic
ejercicio
exercise, there has
terapéutico una
to
lesión
be
de base.
an injury.
Bien, pues,
But
si nosotros
if you
vamos
use
a
a schematic,
contextualizar esta lesión
Jim
de
Cook's
base,
schematic
sirviéndonos del
model from
modelo
2016,
esquemático que
which
nos
talk
presentó
about the
Jim Cook en
function
el año
of pain
2016,
and
donde hablaba de la
injuries,
función del dolor y de la propia
we
lesión, de la
can
propia
put the
patología,
injury
creo o
into
considero
context.
importante que demos un matiz dual a esta ponencia o a esta conferencia.
What does the model
¿Cuál es
say?
ese? Bien, pues
Well,
entender qué
having
pasa
a
en la
look at
periferia
peripheral
y entender
areas
qué pasa
and
a
at the
través de la
perception
percepción
of
de
symptoms.
nuestros síntomas.
Let's talk about, for example, a
Si nosotros
muscle
cogemos como
injury,
referencia una lesión muscular,
fiber rupture,
vamos a poner por
which
caso
is one
una
of the
rotura de fibras,
cases
que
we're
es de la que
better
más se sabe
equipped to
y de la
treat.
que más grave nos podemos
Then we're able
enfrentar.
to design a
Pues,
number
podemos
of
ver en la
biological
literatura todos los
reparation
procesos de
processes that
recuperación
go
y
hand in
reparación
hand with these
biológica que
injuries.
acontecen cuando aparece ese tipo de lesión.
About
Que
28
son conocidos y
days
sabemos que en torno a esos
after
28 días, un mes
the injury, there will be sufficient scarring and sufficient progress will have been made to fully sort out any pre-existing problems. How can we foster the reparation of tissue? It's important because we want to recreate quality tissue when we're repairing muscle in the world of sports. The days a player is inactive actually entail a cost for the club, but it's paramount that athletes are given enough time to recuperate properly. Let's have a look at how we can, as physiotherapists, condition tissue reparation at a cellular level. In this study, which was conducted on animals, almost all the studies I've been able to look at have been conducted on animals carrying out muscle biopsies to treat rupture, but there's a common denominator that a lot of emphasis was made on satellite cells. As you know, satellite cells later specialize into a different type of cell, and they greatly foster this rehabilitation process. In this study that I'd later talk about, we can appreciate how in the first 18 hours these satellite cells decrease in number in the area where the injury occurred, no matter what kind of injury it is. This means that throughout the first 18 hours of becoming injured, it's important to treat and condition the injury properly. Over the course of a month following the injury, the growth of these satellite cells is exponential to a point where their initial numbers can actually double up or triple up. This is important because, again, when we're repairing muscle, what we want to do is attract as many satellite cells as possible and get them to create quality muscle to replace the muscle that was lost. So the question is, can we in any way foster the growth of these satellite cells? Let's have a look at the behavior of these satellite cells. They tend to proliferate in instances of hypertrophy. They become bigger, and once they do, they generate even more satellite cells in the area where the injury occurred. And this happens when you use processes that foster tissue regeneration. So when there is an injury, in a way or another, a new pool of these satellite cells is created. These cells later activate, hypertrophize, increase in number, and create new tissue, quality tissue. They're not, of course, the only cells that are involved in muscle reparation processes. They're all very important. But considering what we've been able to observe in the literature, I would like to stress the fact that in therapeutic exercises, satellite cells are most likely to be properly fostered to bring about proper high-quality muscle reparation. So these satellite cells, as I was saying, can specialize in other types of cell because they are plastic in nature. But the question is, how can we get these cells to do this? Where are these cells? They normally found in blood. But when we get injured, blood vessels break and we lose some of these cells. So the follow-up question is there any way of fostering the angiogenesis of our muscles that have been injured so that we can attract more satellite cells to the location of the injury. And how do satellite cells respond to external stimuli in subjects that are healthy and exercise often? Strength training can increase the number of satellite cells in one's body by 70%. So exercise is a great way of creating a proliferation of satellite cells in the muscles. The follow-up question is it healthy to do strength training on a muscle that's been injured? Probably. But before I tell you more about this, let's reflect on something together. Through exercise, we create more satellite cells and we get them to specialize. But if you've had an injury and you exercise a muscle that's been injured, you will further break it. So it's very important to understand that exercise, while on the one hand it will foster the growth of satellite cells, there is a risk that it may damage us even further. Concentric exercises, for example, are great to treat tendinopathy, but they can also be the cause of tendinopathy. If you understand this, then we can apply the same concept to muscle. We can generate muscle contraction to foster the growth of satellite cells. So strength exercises can be isometric, can be based on exercises that only engage the injured muscle peripherally. On the other hand, there is another type of exercise that we should familiarize ourselves with, and it's aerobic exercise. In aerobic exercise, this study observed that aerobic exercise fosters the growth of satellite cells up to 250%. So if an athlete has suffered an injury, is it okay for him or her to undergo aerobic exercise? Yes, but you have to control the loads. Aerobic exercise, well, we have lots of tools for nowadays. Mountain bikes, swimming pools, anything we want, really. We have a wide array of tools at our disposal. And it's easy to customize these exercises, to tailor-make them to the needs of our injured athlete. So we can do all of this to foster the reparation of tissue through the growth of satellite cells. In 2009, Kane and Scott talked about the effects of mechanotherapy. Mechanotherapy means using the mechanical strength that you use when you exercise and translate it into energy. This energy will regenerate myotubuli and as a result activate these satellite cells in the area of the injury, which in turn will create a lot of benefits for our muscles, which will be better repaired. In our literature, there are several different articles that talk about analgesia or the symptom perception in athletes. But having said that, what kind of exercise is best suited for this purpose? There are lots of publications in favor of isometric contraption, but that's not the only option we have. Strength training and anaerobic training are both able to change the way in which our satellite cells are activated, and as a result they're capable of improving the quality of the new tissue that is built. On the other hand, we have perception, symptoms that are associated. The first symptom that is most often associated with an injury is pain. Pain is one of the key issues that we need to understand if we want to reduce and control symptoms. One, if peripheral exercise is capable of repairing damaged tissue, we also need to understand that it's important for our brain to generate endogenous analgesia. So what kind of contraction is best to reduce pain?
muscular es mejor para reducir el dolor o una patología. Mira,
we have a lot of scientific evidence in support of the fact that exercise in general can be used therapeutically, but not just any exercise. It has to be an exercise we fully understand. Sedentary individuals compared with active individuals who exercise. The key concept here is an NDA, a receptor that is going to affect pain perception. Sedentary individuals aren't able to generate these connections. A trained individual is way more likely to generate endogenous analgesia. So therapeutic exercise for a sedentary individual can entail a number of problems. One, the subject is not used to exercise, and two, they're not going to understand the processes that we're proposing because they have to adapt to it first. It's normal when you start exercising, you don't go from 0 to 100. Before we achieve the proper level of neural adaptation, it takes time. If my tissue has been repairing biologically for a month, but it takes me a month to learn an exercise, to learn how to properly perform an exercise, it doesn't make any sense for me to repair that muscle through exercise. So it all depends on the subject. If my patient is sedentary, is not sedentary, and they're able to perform the exercise, they will generating endogenous analgesia. If a sedentary individual does it on the other way, the extent to which analgesia is endogenously generated won't be sufficient to provide relief. In my opinion, everybody should be embracing the concept of therapeutic exercise, but that's something that needs to be understood. Because the purpose of therapeutic exercise is to trigger off an analgesic reaction in our brain, which again can be activated through exercise. On this slide you can appreciate how all the systems that are activated during exercise have a common denominator. They all lead back to the central nervous system, but that's not the only system involved in this process. Part of the peripheral system also has to do with it. What is it we know about endogenous analgesia? First off, we know that beta endorphins are more easily produced during and after high-intensity exercises. That's a plasmatic production. It's not the same to exercise just because you want to do it and to exercise at a high level of intensity. So high intensity is fundamental here. How do you do that? How do you increase intensity? Well, you up your heart rate, for example. That's one of the ways we have of measuring this. Heart rate is something we can use to monitor the conditions in which patients are working. Heart rate can increase up to 80-85%, and if it does, it means that the exercise session has likely had the effect we were after. So an aerobic exercise, high intensity aerobic exercise, and strength training literature tells us that these plasmatic increases in beta endorphins will also be present. They were responsible for the activation of the relevant system. Another important thing that we've been able to appreciate is progressive exercise or intermittent exercise is not the most adequate type of exercise to generate this change. So that wouldn't be one of the best solutions at our disposal to foster regeneration and analgesic reactions. The duration of exercise also has an influence over this. How long we're capable of working at a high intensity, the longer we're able to do so, the more endorphins will be releasing into our vascular system. And as a result, the better the analgesic effect will be. We also talked about isometric exercise as a source of natural analgesics. We've also studied the opioid effects of analgesic. It doesn't mean that plasmatic beta endorphins don't generate analgesia, they do, but through a different pathway. Why is this important? Because beta endorphins, because they're released into the blood flow, they will have a longer lasting analgesic effect. This means that this opioid system will be active for longer endogenally. Serotonin is also another system we can look at. Well, the serotonal system rather. It's a system that we can stimulate through the nucleus of the diaphragm magnum, which will generate a very positive effect. By doing this, we will interrupt the flow of non-detective information in the spinal cord. On animals, we have found that at high intensity, we have been able to activate serotoninergic effects that can generate endogenous analgesia. If a subject has chronic pain, for example, in the lower back area, well, patients who suffer from low back pain but don't exercise increasing the intensity aren't able to activate this serotonal process. So it's important to exercise at high intensity and for quite some time in order to generate serotonal and opioid mechanisms. Another thing we can talk about is the role of the cardiovascular system and catecholamine. Catecholamine can be activated through adrenergic receptors. These receptors are found in the locus system, for example, and they can activate it mainly through aerobic exercise, resistance exercise, or exercise in warm water. Like opioid systems and serotonal mechanisms and systems, we haven't been able to correlate this with an increase in intensity over time. So, from context, we understand where and how these mechanisms can be activated, but we still lack information regarding its proper activation over time. More systems. Endocannabinoid system. It's a synaptic system. Proteins that couple up with the local membrane. These proteins are found in different areas throughout our central nervous system. When these proteins become activated, they reduce the rate of occipital firing. And how can we activate this analgesic system? Intensity, once again. Which kind of intensity? Average, well, medium-high intensity. It wouldn't be 80-85% heart rate, 80-85% increase in heart rate, but probably around 65 to 70%. This is also capable of activating an analgesic reaction.
esa excitabilidad de las vías nociceptivas. Bueno, también
isometric exercise can lead to a reduction in pain. This can be a great way of reducing pain as a result. And finally, I'd like to talk to you about anti-inflammatory ketokines. This is one of the most interesting mechanisms we have to generate analgesia. These substances can reduce inflammation thanks to increase of interleukin 100 and pre-inflammatory interleukin, etc. How can we activate anti-inflammatory ketokine? Through regular exercise. Earlier, we talked about the need to fully understand what kind of patient profile we have that we're working with. If it's an athlete or a physically active patient, this process can be activated a lot more easily than sedentary patients. We also know that aerobic exercise is going to suppress in the area of the injury, is going to suppress relative to the corresponding spinal area the release of ketokines in the surrounding ganglions. So to sum up very quickly, what is the message I'd like to launch today? First,
lo primero, si nosotros miramos una prueba de imagen, en una prueba de imagen vamos a ver un daño tisular.
If we have a look at an MRI, we can see that in the case of an injury, there is some damage, of course, that has been done to the muscle. We want to treat that. We can foster the proliferation of satellite cells. Through exercise, we will improve the pre-existing structure, but that alone is not enough, because we also have to engage the central nervous system, which is something that can be done in order to generate analgesia. We're capable of generating analgesia through exercise too, so that our injured athlete can understand that this exercise is therapeutic for two reasons. First, because it will relieve pain, and two, because the same exercise is going to help us modulate, remodel the area that's been affected by the injury. So the message I'd like to launch is, exercise is therapeutic per se. Concentric, eccentric, or isometric exercise, all these varieties, they're all necessary because all exercise helps us repair the tissue that's been damaged. So that's my takeaway message. I hope you enjoyed this talk. I'm sorry if I ran slightly over time. You can contact me at the addresses that you can see on screen. If you've got any doubts, please feel free to drop me a line. I'd like to thank the organization for the invitation, and thank you for following us. Thank you, Dr. Jaime Salón. It's truly a privilege for us to have worked with you, physiotherapists of Real Madrid's first team. We do understand that you have a lot of work to do, so we truly appreciate you joining us today. We're running a bit over time. There are a few questions I'd like to ask you. First off, starting with Dr. Carlos, thank you and congrats on your presentation. It's been a pleasure to talk to you. You're so curious. You're constantly thinking about potential innovations, new solutions, new tools. So I wanted to ask you, Technologically speaking, where is innovation headed? Towards prevention, for example, injury prevention, towards treatment? Well, in my field of experience, which is mobile technology, because it's a sort of technology, it's a type of technology that can truly reach everyone, I would say that what's peaking at the moment, especially thanks to Apple, which is a very innovative company, is preventive technology. We're working a lot on augmented reality. Apple has been working on it for 3 years. We're making incredible strides. AR consists in overlapping layers of augmented reality onto the reality we normally interact with. It's digital layers that we're just placing on top of what we can normally perceive. I think this is where technology is headed. Use devices like your smartphones, for example, and or maybe goggles in the not too distant future, and through them, in real time, as you look at a performing athlete, you can see, for example, how high the athlete is jumping, how fast they're running, etc. Right now, I'm working on a rudimentary version of an AR app. The technology, again, is not ready yet, but it allows us to place real-time markers on the joints of our athletes so we can see how they move as they perform. So it's great, truly. All you need is some goggles or your phone, and you can have access to a number of different stats about a given player. Thank you very much, Carlos. Thank you for talking, for serving as a linking node between technology and science and healthcare.
So, this gives a logical, objective support to controlling risk factors and to have better performance. That's not my area, but we're all there we're all here to ensure sports performance. And if they don't have good performance, then we're not doing our job right. So look, thank you very much, Carlos. David, we have a question here. It's very interesting. What are the criteria and the key points in this tendinopathy, this part on the back of the foot, the pain there that a lot of runners suffer from? A lot of paddle players as well, in a lot of social sports. What are the key points? Yes, thanks for the question. Before I answer, I'd like to thank all the speakers, the moderator, and all the technical team, because there's the work in these workshops. There's a lot happening in social media, and it's very exciting. Now, with tendinopathy, it's like having a plastic bottle with lots of holes, and a little bit of water comes out from every hole. If you don't cover all of them, water will come out. So the key to management is what Vassalova said, is objectification. What that means is that we have more information. We have the qualitative and quantitative side of things, and we have to manage both aspects. So the key in the conservative treatment, there are 3 key points. One of them is orthopaedic treatment. And orthopaedic treatment includes footing. There has to be the the right shoes. You have right footwear. Now, there's a publication where we've seen that the top level athletes use the right sort of they have to use the right sort of shoes, the football shoes. So there's a multidisciplinary research, and there's also an individual aspect. So we do qualitative and quantitative analysis, and multidisciplinary and individual. Because we always make mistakes, but the more information we have, the fewer mistakes we make. Okay, thank you very much. Thanks, David. Thanks, Carlos. Thanks, Dr. Leyes and Dr. Jaime Salon. It's a great pleasure to end this international workshop with a round table with such renowned and expert speakers. And you're wholly devoted to your work, and it's very, very interesting to learn from everything you had to say. So thank you very much for making this round table so interesting. Right, to finish this workshop, I'd just like to summarize this international workshop on sports injuries. We can say that all of the speakers have talked about the importance of multidisciplinary work, so physicians, physiotherapists, podologists, physical trainers, nutritionists, psychologists, and other people who work alongside the athlete. And of course, we have to remember that the athlete is the real center of all this, is the protagonist. We all have to take care of the athlete's health. We have to prevent injuries. We have to be available to the athlete and provide all of the technology that we can. And this helps us to focus really on the needs of the athlete and all the different the whole system of the body, the tissues, the functional, the structural aspects, the psychological aspect, and of course the social environment of the player. Now, at all stages in our life, and now as well. Now, before saying goodbye, I'd like to really thank the huge interest that all of the speakers have given. We've had your full participation. Thanks to all the technicians who've made this possible. So thank you very much for all the great work that you've done. Thanks to the Universidad Europea de Madrid and the Real Madrid School, and especially to Victor and all of the members of this institution who've directly and indirectly participated in these workshops, and to all of you who've made this possible. All of my colleagues from a special Diego Miambris for the very hard work and making this possible. All of you have contributed, and it's soon it will be 13 years together in Prima Madrid. And of course, thanks to my family for the solidarity they've shown every day and all the dedication. And as a last message, we are better united and we'll go further together. And if we look for benefits to others, we get better results for ourselves. So it's been a great pleasure to share these couple of days with you. And thanks very much to everyone.